Your seat, please.
Okay. Good afternoon, everyone, and welcome to Genova. It's a pleasure to be here in this fantastic scenario like Palazzo Ducale in one of the most beautiful cities in Italy. My name is Luana Ravegnini. Since 2021, I'm hosting a health-related TV program named Checkup, broadcasted on Rai Uno.
My name is Roberta Villa. I'm a medical doctor by training, but for the last 35 years, I've been working as a health and scientific journalist. Before starting, let me remind you that the event will be mainly in English, but in the beginning, we will have some institutional greetings that will be in Italian. So, if anyone needs it, we have a simultaneous translation service that you can use with no problem taking your headphones out there. Now, the G7 technical event organized by the Italian Ministry of Health is embedded within the third health working group of the G7 presidency. That has been hosted by IIT, the Italian Institute of Technology. Sorry, EET, because they want it to be called in the Italian acronym.
Yes. This meeting focuses on the second priority of the G7 health track, lifelong prevention for healthy and active aging. It's not a coincidence if we are here in Liguria region. This is where there are two of the oldest provinces in Italy. Life expectancy has increased over the past centuries, and G7 members are witnessing a constant aging of their populations, which puts healthcare system under pressure. In this context, the role of prevention in any moment of our life is indispensable to save lives and foster healthy and active aging. We are living in an exceptional period of innovations, which offer new opportunities, for instance, to design biomedical solutions.
During these 2 days, high-profile speakers from a wide range of diverse professional backgrounds will provide a comprehensive overview of these two main pillars, delving into epidemiological relevance of prevention and the sustainability of investing in it, as well as the biomedical, digital, AI, and robotics application for innovation in healthcare. Sometimes a picture is worth 1,000 words. So please, let's watch together the kickoff video for this event that was realized by the Ministry of Health. The title is A Long Journey to Healthy and Active Aging.
It is the lifelong dream of humanity to live longer and healthier. Life expectancy has been increasing dramatically since the beginning of the 20th century. Science and research ensured better living and working conditions, the prevention and control of infectious diseases, the advancement of diagnostic and therapeutic capabilities, and the development of healthcare. The number of people over 65 is expected to reach 16% in 2050 and 24% by 2100. The trend is taking place worldwide, though some geographical differences are expected. In the EU, there will be 26 million people over 85 and 500,000 centenarians. The world is growing older. We will be wiser and more experienced, but we need to face some economic and social challenges: chronic diseases, aging workforce, costs of pensions and welfare, sustainability of healthcare systems, economic growth. The real challenge for a longer life is also to be healthy and active. In 27 OECD's member states, 16% of people over 65 live with severe limitations and 33% have milder limitations. Today the question is, are our extra years lived in good health? Limiting the impact of disability and supporting active aging is essential. There are 5 places, the so-called blue zones, where many people already live an exceptionally long life. The recipe of their lifestyle is a mix of physical activity, healthy diet, low stress and social interactions. Most of the world still needs to embrace the right policies and behaviors to avoid the risks of the aging process. Thanks to the scientific evidence, we are now aware of the importance of healthy eating, physical activity, healthy lifestyles, at all ages. We also know the main risk factors and how to prevent them. By avoiding smoking and alcohol misuse and abuse. Promoting healthy and safe environmental and working conditions is also crucial. Innovation accelerates even faster: robotics, artificial intelligence, smart devices and applications are transforming our life. An unprecedented change is shaping our social and work life and is driving forward the healthcare revolution. Digital health and personalized medicine, prosthetics and regenerative medicine allow patients with osteoarticular diseases to resume their active life. More accurate diagnoses and more effective treatment for many chronic degenerative diseases. A real turning point in the centrality of the patient's needs and toward a human-centered approach. Technology, however, is not enough to guarantee a healthy life alone. Our expectations and behavior are essential. Prevention is fundamental since the first years of life to ensure the well-being and to reduce inequalities for a more sustainable and productive society.
Diciamo che sono passato da macchina a umano. La forza che mi ha sostenuto in questo percorso è stata la voglia di vivere. Io avevo un obiettivo, di arrivare al trapianto e di vivere. Questo io l'ho perseguito fino alla fine.
Innovation is a tool. Prevention is a choice. Investing in both is a commitment that each of us should make for ourselves and for our community.
Very emotional.
Now that the video has introduced us into the theme of this meeting, let me ask our authorities, the attending authorities, to address some greetings. As I said before, now I will switch to Italian. Prima di tutto lasciatemi accogliere con un applauso il Ministro Orazio Schillaci, che invito al podio. Prego, Ministro. Il nostro Ministro è medico specialista in medicina nucleare, professore ordinario e ex rettore dell'Università Tor Vergata di Roma. Ministro, le due tematiche di cui già abbiamo accennato sono state proprio al centro del suo mandato sin dall'inizio, quindi le do volentieri la parola.
Grazie, buon pomeriggio a tutti. Saluto il Sindaco Bucci, il Vice Presidente della Regione, Presidente facente funzione Alessandro Piana, l'Onorevole Rosso, l'Assessore Grattarola, Giorgio Metta, che è il Direttore Scientifico dell'Istituto Italiano di Tecnologia, lo ringrazio per aver contribuito alla realizzazione di questo evento, Stefano Scarpetta, che è responsabile della Direzione per l'Occupazione, il Lavoro e gli Affari Sociali dell'Ocse. Vi porto poi i saluti del Sottosegretario Marcello Gemmato, che non può essere qui per impegni personali e di cui credo dopo aver letto un messaggio. Saluto e do il benvenuto agli autorevoli esperti internazionali e nazionali che partecipano a questo evento tecnico-scientifico che come Ministero della Salute abbiamo voluto promuovere nell'ambito dei lavori preparatori alla ministeriale del G7 Salute di Ancona che si terrà il prossimo ottobre. Quello del G7 è un percorso lungo, è iniziato già alla fine dello scorso anno con una serie di incontri bilaterali, di approfondimento e anche all'interno della nostra comunità e con le altre nazioni del G7. Sono 3 le priorità che ci siamo dati per il G7 della salute, che abbiamo condiviso con tutti gli altri partner. Il rafforzamento dell'architettura sanitaria globale, l'antimicrobico resistenza in una ottica di One Health e la prevenzione lungo tutto il corso della vita legata all'invecchiamento attivo. Queste sono priorità sostenute anche nel comunicato finale dei leader riuniti nel vertice in Puglia recentemente, che dimostrano la centralità che la Presidenza italiana ha voluto dare alla salute. Il nostro cammino verso la ministeriale di Ancona va avanti con una serie di incontri tecnici, di confronto con la società civile. Ieri qui si sono riuniti gruppi di lavoro che stanno approfondendo questo percorso. Per la priorità legata all'invecchiamento attivo abbiamo scelto Genova, perché la Liguria è un hub di innovazione della regione più anziana d'Europa con l'età mediana più alta, dove quindi c'è grande attenzione e sensibilità verso le politiche per l'invecchiamento. Abbiamo voluto un evento di ampio respiro scientifico per mettere insieme prevenzione ed innovazione anche in un'ottica internazionale. Sono convinto infatti che l'universalità e la sostenibilità di tutti i servizi sanitari passa per uno sforzo comune affinché la prevenzione sia un asse portante insieme all'innovazione tecnologica. L'invecchiamento attivo in salute è una via obbligata. Basta guardare agli scenari demografici che indicano un costante e progressivo aumento della popolazione anziana. Il video che abbiamo appena visto ci ricorda che gli over 65 in Europa nel 2050 potrebbero arrivare ad essere il 16% della popolazione, arrivare a un quarto della popolazione nel 2100. In Italia oggi gli over 65 rappresentano il 24% della popolazione. Dovrebbero arrivare al 34% nel 2050 e crescono anche i cosiddetti grandi anziani. Gli scenari demografici prevedono un consistente incremento sia della popolazione degli ultra-ottantenni che degli ultra-novantenni. Se non interveniamo però, questo invecchiamento determinerà una maggiore incidenza di malattie non trasmissibili, con chiare ed evidenti ricadute, come capite, sullo stato di salute ma anche sui costi sanitari e sociali. Ecco perché dobbiamo fare in modo che questa longevità sia accompagnata da politiche che favoriscano più anni in buona salute. Dobbiamo promuovere veramente, come dico sempre, un cambio di paradigma. Oggi abbiamo un servizio sanitario prevalentemente fondato sulla cura, solo il 5% delle risorse del fondo sanitario è destinato alle attività di prevenzione. Mia intenzione è aumentare la percentuale del fondo destinato alla prevenzione. In questo modo vogliamo potenziare le politiche di prevenzione, penso agli stili di vita corretti, alle attività di screening, in particolare quelle oncologici. La prevenzione deve riguardare tutto il corso della vita, fin dalla fase prenatale. L'educazione a stili di vita salutari deve iniziare dai più piccoli, proseguire durante l'età adulta e anche in età avanzata. Il 60% del carico di malattie in Italia, come in Europa, è riconducibile infatti a fattori di rischio modificabili con stili di vita corretti. La letteratura scientifica dimostra come, ad esempio, la corretta alimentazione e l'attività fisica contribuiscano a contrastare l'insorgenza di malattie cardiovascolari, obesità e malattie come il diabete di tipo 2, alcuni tipi di neoplasie, patologie neurodegenerative, che rappresentano un rilevante problema sociale oltre che sanitario. I recenti dati della sorveglianza passi dell'Istituto Superiore di Sanità aiutano a capire che se i giovani e gli adulti di oggi invecchieranno in salute e come intervenire. Abbiamo un 28% di sedentari, con un aumento dal 2021 in maniera più evidente soprattutto nelle regioni del Meridione. Il 10,4% degli intervistati risulta obeso, il 43% è stato consigliato di perdere peso. Al 18% delle persone fra i 18 e i 69 anni nel corso della vita è stata diagnosticata una o più patologie croniche. E proprio la cronicità coinvolge di più le persone con uno status socio-economico svantaggiato. Sono numerosi i dati che ci indicano veramente la necessità di invertire il trend. Vanno incoraggiate le persone a cambiare i propri comportamenti e a essere protagoniste del proprio stato di salute, a partire da una corretta alimentazione, valorizzando quelle che sono le nostre tradizioni. Penso ai benefici sulla salute della dieta mediterranea, che io chiamo italiana, che sono dimostrati da tanta letteratura scientifica. Abbiamo intensificato le campagne di promozione sugli stili di vita corretti, sui programmi di screening oncologici. Dobbiamo fare veramente in modo che i cittadini scelgano di avere cura di se stessi per guadagnare più anni in buona salute. L'altra leva fondamentale per l'invecchiamento attivo e in salute è l'innovazione. L'Italia vanta numerose eccellenze. Oggi abbiamo raggiunto traguardi un tempo impensabili. Questo è merito del progresso della scienza e della ricerca, che hanno migliorato terapie ed assistenza. Ne abbiamo di esempi tanti qui oggi nell'area espositiva che ho visto poc'anzi, grazie anche all'Istituto di Tecnologia italiano, con per esempio un prototipo di piede artificiale. L'innovazione in campo biomedico ha un impatto rilevante sulla prevenzione. Le protesi di ultima generazione consentono di continuare ad avere una vita attiva con riflessi positivi sull'invecchiamento. Penso poi all'intelligenza artificiale. Sta già dimostrando il suo potenziale. Guardiamo per esempio a quello che avviene nel campo della diagnostica per immagini. Può rappresentare un valido supporto per i professionisti sanitari anche in tanti altri ambiti. A questo proposito, uno specifico progetto del PNRR affidato ad Agenas investe 50 milioni di euro sulla realizzazione di una infrastruttura di intelligenza artificiale all'interno delle case di comunità, per aiutare i professionisti sanitari nelle attività di diagnosi, monitoraggio del paziente cronico e i cittadini per le attività di prevenzione. Nei processi di assistenza territoriale, l'intelligenza artificiale può agire da fattore di facilitazione per la continuità, l'accesso e la personalizzazione delle cure, con una maggiore efficacia ed efficienza del nostro sistema sanitario nazionale. Ribadisco anche qui che l'intelligenza artificiale è un'opportunità. La dobbiamo saper cogliere con la capacità di coniugare scienza ed etica, perché deve essere chiara la funzione di supporto dell'intelligenza artificiale, che va governata, non subita, all'interno di processi in cui resta centrale il ruolo della competenza e della professionalità del medico e degli operatori sanitari. La sanità digitale poi rappresenta un alleato formidabile sia per l'invecchiamento attivo sia per la prevenzione. In Italia stiamo investendo tanto sulla digitalizzazione, alla quale sono dedicate il 45% delle risorse della missione salute del PNRR. Il potenziamento della telemedicina è indispensabile quando si va sempre più verso terapie personalizzate, verso la medicina di precisione, e lo è anche nella gestione della cronicità a livello territoriale, perché migliora la qualità dell'assistenza. La collaborazione tra i medici di medicina generale e gli specialisti, tutto questo rafforza l'alleanza tra medico e paziente e migliora l'aderenza terapeutica. Per questo, con la rimodulazione del PNRR, abbiamo aumentato l'investimento sullo sviluppo dei servizi di telemedicina anche a supporto del rafforzamento dell'assistenza domiciliare per i pazienti over 65. Siamo stati tra i primi a sottoscrivere l'accordo per la piattaforma nazionale di telemedicina. A breve sarà disponibile un portale per i cittadini e gli operatori per diffondere la conoscenza degli strumenti di telemedicina. Così come abbiamo impresso una fortissima accelerazione al fascicolo sanitario 2.0. Questo è uno strumento che darà un contributo fondamentale anche in termini di prevenzione primaria e secondaria. Nel corso di questi 2 giorni tutti questi temi saranno approfonditi. Sono certo non mancheranno riflessioni e proposte utili per supportare le politiche che stiamo e che vogliamo mettere in campo. Grazie a tutti per il vostro contributo e buon lavoro.
Grazie. Grazie al Ministro Schillaci. E come diceva il Ministro, oggi avrebbe dovuto essere qui con noi l'onorevole Marcello Gemmato, per motivi personali non è potuto venire, però ci ha tenuto a lasciare un messaggio che vado a leggervi. Buon pomeriggio a tutti. Desidero esprimere sincero rammarico per non poter presenziare a questa seconda riunione tecnica preparatoria della ministeriale del G7 Salute del prossimo ottobre ad Ancona. Rivolgo i miei saluti al Ministro della Salute Orazio Schillaci, all'amico deputato Matteo Rosso e a tutte le autorità e agli illustri relatori nazionali e internazionali che partecipano a questo evento dall'alto valore tecnico-scientifico. Il tema della longevità e della prevenzione per favorire un invecchiamento attivo è comunque sentito da tutti i paesi del G7 ed è un fattore che contribuisce ad orientare le politiche sanitarie, economiche e sociali. L'aspettativa di vita globale è in aumento e ad oggi la differenza fra agli anni della vita vissuta e quelli spesi in buona salute o in assistenza di malattie fotografa un gap di 9 anni, caratterizzati per lo più da condizioni di fragilità e disabilità. Queste considerazioni spingono a riflettere sull'importanza della prevenzione e della corretta gestione delle cronicità. Occorre investire adeguatamente in educazione sanitaria, promuovendo a tutte le età corretti stili di vita e una sana alimentazione, che in Italia ha un alleato indiscusso costituito proprio dalla dieta mediterranea, che è riconosciuta come patrimonio UNESCO. Nella gestione delle cronicità molto può giocare la sanità digitale, grazie alla telemedicina e alle potenzialità dell'intelligenza artificiale applicata al dato sanitario per una medicina predittiva e di precisione. L'attuale governo ha già messo in campo iniziative per potenziare l'innovazione sanitaria e portare la cura al domicilio del paziente. Cito l'esempio della farmacia dei servizi, la cui sperimentazione proprio qui nella regione Liguria ha dato risultati eccezionali in termini di prestazioni di telecardiologia erogate in convenzione col Servizio Sanitario Nazionale, che contribuiscono all'abbattimento delle liste d'attesa e che facilitano l'accessibilità alle cure per i cittadini. È da questi nuovi modelli organizzativi che passa la ridefinizione del nostro Servizio Sanitario Nazionale, in ottica di modernizzazione e di sostenibilità. Sono certo che dal confronto di questi 2 giorni scaturiranno numerosi spunti di approfondimento per il prossimo appuntamento e per delineare strategie a supporto del benessere e della tutela della salute di tutti i cittadini. Con l'augurio di un buon lavoro invio i miei cordiali saluti. Onorevole Marcello Gemmato, che ringraziamo con un applauso. Grazie. E io so che abbiamo qui anche il presidente ad interim della Regione Liguria, Alessandro Piana, che inviterei a raggiungerci qui sul palco, anzi raggiungere il podio. Potete anche farlo. Prego.
Grazie, buon pomeriggio a tutti. Ovviamente saluto il Ministro Orazio Schillaci, il Sottosegretario Marcello Gemmato, che ci ha mandato un bellissimo messaggio, il Sindaco Marco Bucci, l'assessore e collega Angelo Grattarola e l'onorevole Matteo Rossa, che è anche responsabile della sanità per Fratelli d'Italia a Roma, al Governo, al Parlamento. Regione Liguria ovviamente ha un contributo importante da veicolare su questa tematica che caratterizza appunto la posizione degli over 65 ed è ovviamente come regione tra le prime in Europa. Noi diciamo sempre per fortuna, perché vuol dire che da noi si vive bene, si invecchia bene e anche l'assistenza sanitaria è adeguata a quelli che sono ovviamente i canoni. Possiamo infatti portare in evidenza un'esperienza pluridecennale nell'ambito specifico utilizzando 2 chiavi di lettura. La prima per livelli di prossimità, ovvero tutti quei servizi che vengono fatti, inclusione, servizi domiciliari e prossimità stessa, e soprattutto quella dell'attivazione degli anziani in attività di natura culturale, sportiva e ambientale. In questo caso infatti la persona anziana viene considerata non solo come oggetto di cura, ma anche come soggetto attivo che esprime la propria identità sociale all'interno di un vero contesto e appunto partecipando attivamente a quella che è la vita sociale, ma anche economica e culturale, proprio della comunità di riferimento. La Regione poi lo spiegherà ovviamente in maniera più specifica l'assessore Angelo Grattarola, però ci tenevo a specificare alcuni concetti importanti. La Regione come macro obiettivo, come previsto dal piano sociale integrato regionale 24-26, che è stato approvato recentemente nel mese di febbraio del 24, nel nostro Consiglio regionale predisporrà un innovativo piano regolatore per l'invecchiamento attivo, ovviamente di concerto con le associazioni sindacali maggiormente rappresentative del nostro territorio regionale, il terzo settore e tutti gli stakeholders pubblici e privati, proprio partendo da quelli che sono dei dati oggettivi per poi attuare quelli che sono i processi di sperimentazione e valutando l'esito mano a mano. Ci tenevo in modo, concludo perché poi ovviamente gli interventi sono tanti e io stesso non vedo l'ora di poterli ascoltare con attenzione. Concludo nel ringraziare ovviamente il Ministro Schillaci e soprattutto la sensibilità che il Governo ha voluto, diciamo così, dare a Regione Liguria proprio per la tematica specifica nella nuova ridistribuzione del fondino sanitario. L'assessore Grattarola per il grande lavoro fatto con dei dati oggettivi che hanno, diciamo così, certificato quella che è la realtà ligure e soprattutto l'onorevole Matteo Rosso, che è stato anche presidente della Commissione Sanità in Regione Liguria, conosce benissimo la tematica e conosciamo tantissimo, io poi ho collaborato con lui diversi anni, conosco la sua sensibilità specifica in materia ed è una vera e propria garanzia come Regione Liguria al Parlamento per una tematica che noi consideriamo essenziale per il nostro territorio, che non è soltanto, come ho detto precedentemente, una problematica e quindi un'assistenza vera e propria, ma una vera e propria opportunità. Da noi si vive bene, si invecchia bene, le cure ci sono e soprattutto nei periodi estivi abbiamo anche la forza di prenderci cura di tutti quei tanti turisti, anche anziani, che vengono dalle regioni di prossimità come il Piemonte, la Lombardia, il Veneto, l'Emilia-Romagna, la Toscana, ma anche da altre nazioni perché, ripeto, nel nostro Paese abbiamo un sistema sanitario che fa un po' invidia a tutto il mondo, anche se spesso viene criticato ingiustamente, e Regione Liguria ovviamente si ritaglia uno spazio di tutto rispetto all'interno del panorama nazionale.
Grazie Presidente Piana. E noi andiamo avanti perché in rappresentanza della Regione Liguria sono lieta di introdurre l'assessore alla sanità Angelo Grattarola, che invito a raggiungere il podio. Buon pomeriggio.
Buongiorno a tutti, grazie signor Ministro per essere qui, per aver voluto che questo convegno fosse proprio a Genova. Congresso che parla di invecchiamento e di come renderlo attivo, cercando di migliorare il percorso della vita, non soltanto attraverso il controllo delle patologie, ma garantendo un reale benessere. Il nostro è un Paese che ha un tasso di mortalità tra i più bassi d'Europa, che ha una migliore, forse uno dei primi 3 stati in tema di attesa di vita alla nascita, però le fasce di età avanzate sono minate, diciamo, dal loro stato di salute e dal benessere che non è spesso ottimale, non solo per le cronicità, ma anche per altri elementi negativi quali la solitudine oppure le difficoltà sociali. La Liguria è certamente una delle regioni più anziane d'Europa. C'è un dato Eurostat di qualche mese fa che lo certifica insieme a qualche Länder tedesco e rappresenta davvero quello che l'Italia sarà nel 2045, nel 2050. E per questa ragione è un naturale laboratorio nel quale sperimentare quegli approcci organizzativi che sono utili alla presa in carico dei pazienti anziani che sono portatori di patologie croniche e che debbono trovare le loro risposte non tanto all'interno degli ospedali, ma in prossimità dell'area in cui vivono. Lo slogan "La casa come primo luogo di cura" è la sintesi che scaturisce dall'impegno sancito dal decreto 77 che grazie alle risorse del PNRR può davvero cambiare il volto della medicina territoriale. Con le centrali operative, le COT opportunamente digitalizzate che dal 1° luglio scorso rappresentano le strutture di back office per l'assistenza domiciliare integrata, ad esempio, che in Liguria conta oggi una presa in carico di circa 34.000 ultra 65 anni. Poi le case di comunità, luogo in cui si fondono problemi sanitari, sociosanitari e sociali e che rappresentano senza dubbio un altro pilastro di potenziamento del territorio accanto agli ospedali di comunità che sono un filtro a flusso biunivoco dal domicilio alla struttura ospedaliera e viceversa. Importante certamente il ricorso alla telemedicina in tutte le sue applicazioni che avvicinano il paziente al sistema sanitario, tecnologie che sono in rapidissima espansione, come per esempio i device indossabili, che garantiscono per esempio il puntuale monitoraggio nel tempo per i pazienti che sono più critici. Nella nostra regione vi è poi un aspetto cruciale che riguarda le aree interne a bassa densità di popolazione, nelle quali l'impiego di un approccio come quello che ho appena descritto può garantire coperture sanitarie di alto livello. Questa organizzazione, io sono certo, permetterà di restituire agli ospedali la loro naturale funzione, ovvero curare le patologie acute ed emergenti, riducendo al contempo il sovraffollamento nei dipartimenti di emergenza. È un momento cruciale della sanità italiana, è una battaglia che tutti insieme dobbiamo combattere e dobbiamo vincere per garantire la tenuta del nostro sistema che rappresenta senza dubbio una delle espressioni più nobili del Paese. E tutto questo non è domani, è già oggi. Questo congresso lo ribadisce con il confronto, la condivisione di strategie, visioni, esperienze che permettono ad una delle fasce più deboli della società, gli anziani, un invecchiamento attivo perché, come declina l'Organizzazione Mondiale della Sanità, la salute è uno stato di completo benessere fisico, mentale e sociale e non solo l'assenza di malattie. Buon convegno a tutti e grazie a tutti per l'attenzione.
Grazie. Grazie.
Tocca a me adesso chiamare sul palco il sindaco di Genova, il dottor Marco Bucci. Prego.
Buon pomeriggio a tutti e un caldo benvenuto e warm welcome a tutti quelli che non sono di Genova. La nostra città è molto orgogliosa e contenta, lo è anche il sindaco, che voi siate qui e che possiate passare 2 giorni e forse qualcuno anche il weekend, 2 giorni con noi nella città. Ringrazio il Ministro per essere qui e per aver scelto Genova per questo importante convegno che riguarda proprio una delle potenzialità e opportunità che abbiamo noi nella nostra regione. Ringrazio tutte le altre autorità presenti, non le nomino tutte perché sono tantissime, però è un grazie che viene dal cuore a tutti voi, dal cuore che speriamo stia bene, ecco, mettiamola anche da questi termini. Allora, cosa volevo dirvi?
Allora, 2 o 3 volte nel primo mese.
Non c'è dubbio che siamo sui libri di testo, sui giornali, da tutte le parti, come la città e la regione con più persone anziane. E siamo sinceri, questa cosa sembra una cosa negativa, ha un'accezione negativa nell'opinione pubblica. Noi ci impegniamo per fare il contrario, per dare invece al fatto che noi nella nostra città e nella nostra regione abbiamo una alta percentuale, diciamo, più alta degli altri, diciamo così, perché arriviamo dal 22 al 23, poi insomma, ecco, per parlarci chiaro, di persone anziane, è invece una cosa che dobbiamo vedere in termini positivi. Prima di tutto perché vivere di più è meglio che vivere di meno, questo sembra banale, però in Liguria si vive di più che in altre regioni d'Italia e in Italia si vive di più che in tante altre nazioni d'Europa, quindi pensateci, siamo uno dei posti dove si vive di più e questo non è poco. Però ci deve essere una vita d'alta qualità e questo è l'altro punto importante che noi vogliamo sia associato alle esigenze degli anziani, ovvero sia avere vita lunga ma avere vita di alta qualità. E la sanità è fondamentale, la priorità numero 1 per avere alta qualità di vita. C'è chi sceglie dove vivere i propri anni nei posti dove c'è alta sanità, dove la sanità ha un valore molto importante. C'è chi decide quando è giovane magari di andare a vivere nei posti dove l'education, cioè la scuola, è una componente fondamentale della famiglia. E così succede in tutto il mondo. Anche da noi in Italia comincia a succedere in questo modo e si va a vivere nei posti dove ci sono le cose migliori. Bene, la nostra sanità, che se ne dica, l'ha detto l'assessore Grattarola, l'hanno detto tutti, è un'eccellenza. Io posso dirvi che non sono un uomo bionico, ma un mese fa ho fatto 7 ore di chirurgia e dopo una settimana ero a lavorare. Quindi voglio dire, e non è merito mio, è merito di chi ha fatto veramente un lavoro coi fiocchi. Ecco, qui a Genova succedono queste cose. E non possiamo dimenticarcele, perché se non altro nelle situazioni di emergenza noi abbiamo una sanità che è veramente ad altissimo livello. Prima di tutto dobbiamo dirlo, e io sono qui a dirlo. Secondo, dobbiamo fare in modo che questo continui. E terzo, dobbiamo fare in modo che ci sia sempre un passo avanti. Non possiamo fermarci nella situazione in cui siamo. Dobbiamo avere tutti l'impegno per fare sempre un passo avanti. L'amministrazione pubblica cosa fa? Sapete che il sindaco è responsabile della salute dei cittadini. Deve quindi lavorare assieme alla Regione per far sì che ci siano le condizioni per cui si continui a migliorare sempre il sistema sanitario della città e della Regione. Facendo così otteniamo un sistema sinergico che alla fine dà i suoi risultati. Cosa abbiamo fatto? È ovvio che tutta la componente sociale deve aiutare la persona anziana e soprattutto per quanto riguarda la prevenzione verso la cura. Sappiamo tutti che investire in prevenzione conviene, non solo dal punto di vista dell'allungamento della vita, della qualità di vita, ma anche e soprattutto dal punto di vista economico. Se si investe in prevenzione si risparmia in cura, queste cose ormai le sanno tutti, e deve essere una spinta a fare sempre più prevenzione, che non vuol dire soltanto investire in termini economici, ma vuol dire investire nei termini di educazione dei pazienti. Bisogna convincere le persone a fare prevenzione, non è facile. Bisogna convincere le persone ad andare a farsi visitare, a fare il check, a fare tutte queste cose, e questa è una missione che può fare benissimo l'amministrazione comunale, anche se non è completamente interessata dagli investimenti nella sanità. Quindi abbiamo un incarico e vogliamo fare questo discorso nella qualità di vita e negli obiettivi delle persone che devono avere questa lunga vita. E poi ricordiamoci l'altra cosa, noi abbiamo orgogliosamente, posso dire che qui a Genova è nato il Silver Economy Forum qualche anno fa e l'abbiamo introdotto perché? Perché non dobbiamo dimenticare che l'età Silver Age è anche una grande potenza economica. Le regioni, le città che possono attrarre le persone che sono nel Silver Age hanno una ricaduta economica e occupazionale importante per la città e per la regione, e quindi poter avere un sistema che garantisce un'alta qualità di vita per queste persone dà una importante ricaduta economica e occupazionale sul territorio. La Florida è un esempio per tutti. Io non voglio dire che noi la Liguria è la Florida dell'Europa, perché siamo molto più belli della Florida, quindi non posso fare questo paragone, perlomeno dal punto di vista del paesaggio. Però voglio dire che questa è un'opportunità enorme per noi. Enorme perché poi la ricaduta economica aumenta poi gli investimenti e quello che possiamo fare in sanità. Quindi è un loop sinergico che costruisce un sistema di alta qualità di vita. Questi sono i messaggi che noi abbiamo nella nostra ottica e abbiamo come linee guida della nostra visione di città. C'è grande valore, non vorrei che si pensasse che la nostra città e la nostra regione sono posti dove la gente è vecchia, scusate se uso questo termine, in maniera negativa. Vorrei che si pensasse che la nostra città e la nostra regione sono posti dove si vive bene, ad alta qualità di vita, e anche se si è anziani si può vivere un'eccellente vita. Grazie a tutti e buon convegno.
Mi sembra un'ottima conclusione da parte dell'onorevole Rosso.
Per concludere abbiamo ancora l'onorevole Matteo Rosso,
certo,
che è già stato citato prima, membro della Commissione Affari Sociali della Camera.
Buongiorno a tutti. Citato davvero, grazie soprattutto al Presidente della Regione Alessandro Piana, che ha speso parole meravigliose e te ne sono grato. Tanti anni di battaglie insieme nella nostra sanità, davvero grazie Alessandro. Io sono davvero orgoglioso, commosso come genovese, medico genovese e ligure, prima che come parlamentare, e ringrazio il Ministro per aver scelto di fare a Genova questo momento così importante. Quando il Ministro mi disse alcuni mesi fa lo facciamo a Genova, io ho detto caspita, è una cosa meravigliosa, la nostra è una città, una regione di cui io sono profondamente orgoglioso, i liguri lo sono, ma che spesso fuori non viene valorizzata. Quindi grazie Ministro per averlo fatto a Genova, è un momento davvero molto importante per noi ed è un riconoscimento a tutte le professionalità sanitarie, nella ricerca, nell'innovazione che sono nella nostra regione. Come dicevo prima, spesso troppo sottovalutate, ma che invece sono importantissime. È ovvio, l'IIT è una realtà eccezionale di cui siamo orgogliosi e grati per averla in Liguria, ma io penso anche a tutti gli operatori sanitari, ai nostri ospedali, ai nostri centri di ricerca, perché vedete, l'anziano si cura, è vero, con la ricerca, ma si cura anche tutti i giorni. E noi in Liguria abbiamo una sanità, avendo la regione più vecchia, più anziana d'Europa, in cui i nostri operatori sanitari ci mettono il cuore, la fatica, la passione, e io li ringrazio davvero di cuore, in condizioni molto difficili spesso. Parlare di invecchiamento avete detto tutto voi, non voglio dire altro, è ovvio che è un lungo percorso che parte dall'età adolescenziale, quando insegni gli stili della vita, fino ad arrivare a tutta quella che è l'innovazione. Io non so se la vedrò, ma anche tutta la domotica, non ne capisco niente, me lo spiegano i miei figli, però la domotica, le case intelligenti, tutto ciò che rende la vita più facile anche a chi ha delle disabilità. Penso a mio papà, che è un uomo purtroppo rimasto cieco, per lui certe realtà lo aiutano molto, gli rendono la vita più facile, gli rendono la possibilità di essere anche autosufficiente. E allora io lascio solo un messaggio col cuore, lo dico anche, abbiamo tanti ospiti stranieri, in questi giorni ho letto anche, c'è stato un consiglio regionale in Liguria, di attacchi duri alla sanità. Bene, è vero, leggiamo delle notizie negative, è vero, ci sono dei tempi di attesa lunghi dappertutto, ci sono dei pronto soccorsi che vanno migliorati perché lo dobbiamo ai nostri pazienti, però noi dobbiamo essere anche molto onesti, abbiamo un sistema sanitario che per l'emergenza, se uno ha un trauma acuto, un infarto, un'ischemia, un'emorragia, bene, viene curato immediatamente, benissimo, indipendentemente anche dallo stato sociale e economico che ha. Cioè questa è la cosa molto bella, noi garantiamo a tutti nel momento dell'emergenza le cure migliori in assoluto. Poi è vero, Assessore Grattarola, dobbiamo migliorare le liste attesa, dobbiamo migliorare il pronto soccorso, però dobbiamo anche guardare il bicchiere mezzo pieno. Abbiamo una sanità che davvero a tutti garantisce di essere curati nel modo migliore. Grazie Ministro, davvero grazie a tutti voi.
A questo punto permettetemi di ringraziare un po' tutti gli illustri ospiti che hanno fatto da cornice istituzionale a questo prestigioso evento, quindi facciamo un applauso totalitario proprio per tutti quanti loro. Grazie. Now Roberta, let me switch back to English. It's time to invite on stage our two keynote speakers. They will offer us an overview of the two pillars of this event, innovation and lifelong prevention. Giorgio Metta is the Scientific Director of the Istituto Italiano di Tecnologia, a renowned center of excellence and hub for innovation at the international level and co-organizer of this event. Its main goal is the advancement of science in Italy and worldwide. Through projects and discoveries oriented to application and technology. The scientific area covered by IIT includes robotics, drug discovery, neuroscience, nanotechnology, and computer vision. Giorgio Metta will establish the link between technology, innovation, and health, and will tell us what IIT has been doing in this field. Dr. Metta, the floor is yours, please.
Thank you very much. It's a very great honor to be able to speak here, to present IIT, and thank you, dear Minister, all the representatives of the institutions here in Liguria, but also the delegates of the G7 that are here to participate in this technical event. As you mentioned, I'll go through the innovation. I mean, the two keywords are lifelong prevention and innovation. I'll go for the innovation part, and I'll present, or I'll try to show how the new technology is connecting to healthcare. By the way, let me say that IIT strategic plan, a new one we designed this year, has two main pillars. One is healthcare. It's not surprising, given that we're doing robotics, that we're doing drug discovery. As you mentioned, we're doing computer vision. There are many topics that are disciplines that can actually have an impact in healthcare. Let me start with something that was already said, so I don't have to repeat it much. I like this plot that I reconstructed from an article on The Lancet, a recent one from March 2024, that show something called fertility rate. I mean, I think you know the numbers. 2.1 is the golden number for a steady population. And this plot, you see 2021, the moment data were collected, and you see also 2100, a prediction of what's going to happen in 2100. As you can see, each dot is a country. Probably Italy is one of the yellow dots down there. Africa is probably somewhere around the red dots, but you see something very striking effect. Everything levels around 2.1 or below, which means population is going to decrease. This has an impact, especially in Italy at the moment, is the data I was able to access, showed that in 2040 already we will be lacking people from the workforce. People are living longer, but they simply retire. And I mean, think this is good. But this means also that we have 3.7 million less workers, which means 15% of the GDP. It's a big number. At the same time, if you go to the National Institute of Statistics data, you see that the cost of our healthcare system will increase by about 3%, which is, again, it's a considerable number. The two things together are problematic. Now, wanted to talk about innovation, so this is a negative part, but the good thing is that innovation comes to the rescue. This is an image where or faces that you expect to see in 2040, but also faces that are smiling, that are in good health. So this is the idea that we have of healthcare by then, and also our life status by then. What I wanted to say is this is because exactly of new technology. I mean, the G7 is all about AI as well, and this is not surprising. One key message, or a few messages. This is the Commissioner Verstegen a few months ago speaking about the creation of a European Center for Artificial Intelligence, and she said, what do we want to do with AI? Are we using AI for science, for innovation, for discovery, or are using AI because we like to cook spaghetti and we don't know how to do it? I think the first answer is perhaps the most interesting, and also it's worth the energy that we're spending on AI to actually do that. So AI for science is very, very important. Science is innovation. Another big name of the world of innovation, Eric Schmidt, former CEO of Google, the guy who made Google what it is today, so quite incredible. He says, well, although we only know ChatGPT, basically, or the so-called large language models, in reality, there's so much AI can do for science, for interpreting science. And again, science and medicine and healthcare is quite fundamental. This is an example of why AI may be needed. This is, bear with me, I'm not a biologist, but this came from some of our researchers. We are seeing an increased complexity on managing biological data, or understanding the biology of the cell, understanding molecular biology, where, let's say 20 years ago, the picture was, okay, there are some regulatory elements of the DNA that eventually, being triggered, allow expression of a gene and a translation into a protein. This was the easy, let's say, picture. We're now getting into this very complicated picture where a number of molecules actually determine what is expressed, when it's expressed, whether is the correct one at that moment, and so forth. So the control network is incredibly complicated. And this is where AI can come to a rescue. In a sense, all roads lead to AI. This, by the way, is generated by AI. I asked for a Roman road, since we're in Italy, and some digital elements, and this is what you get. It's quite fascinating, I must say. Now let's go to a more concrete case. This is another good example. I hope I managed to convey the message. So there's clearly a way to, this is the drug discovery, and in particular, we were trying here to find a molecule that has certain effects that were already known as part of a known drug, but removes the side effects. This is the case of bumetanide, a particular molecule that can also be active during neurodevelopment, and in particular regulates the level of chloride in neurons. And we're trying to figure out whether, can we remove the side effect? Side effect is that it's a diuretic. So it's a very annoying problem at the concentration levels that are needed to act on the neurons. So we went through a process called screening. The screening is completely done inside a computer. The result that we found 2 candidates that have the properties. We tested them in vitro. We tested them with an animal model. We ended up with 2 patents, and these 2 patents are now a company called Yama Therapeutics, a small company, a startup, with good funding to try to go to clinical trials for these molecules. It's a long way. It started last year, so it will take some time, but this is an example of how the digital world can actually help drug discovery. And you may think that this is the end of the story, but what I wanted to say is that this is more or less traditional computation. It's very innovative, but it's traditional. AI can do something more, and this is the something more. Here we found an RNA aptamer that interferes with certain protein that is called TDP43. Apart from the name, this is a protein that aggregates in ALS. So it's potentially a molecule that we can send to the cell and disaggregate, these aggregates that actually kill the neurons eventually. So again, it's a possibility. But here, the difference is that the AI is at play, and we are engineering the specific sequence of nucleotides that are needed to interfere very precisely with that molecule. So this is a big difference. We're going from just screening and by trial and error, basically to find a solution to a problem, to a situation where we become the engineers of biology. I think this is a big change, and this is very promising. Of course, also this can become a patent. This is what we've done. Let's see if we manage also to try this beyond the, let's say, the in vitro or animal model and go to human eventually. Let me conclude quickly. There's another big sector or set of technologies where the AI can be fundamental, and this is in controlling machines. And this is an example of some of the machines that you can also see here today. And in particular, I wanted to show you this one. This is a case where the control of the prosthetic is very limited because of basically the quality of the signal you can get from the residual muscles at the amputation. What we can do here is try to interpret these signals from EMG sensors and try to figure out what are the intentions of the patient, and therefore moving the all prosthetic elbow and hand very naturally, as is shown here. This is quite amazing and quite interesting in perspective, allowing to control more and more complicated prosthetics devices. Let me conclude with some economics. This is a plot that matches basically International Monetary Fund data and OECD data and shows the investment in research and development with respect to the average growth of the GDP of a country. And I think this is quite interesting, and the trend is quite clear, and I think it shows that it's not only health, it's also our economy that can benefit from the investment in research and development. I mean, this is obvious because I'm representing research institutes, so you could expect this message coming from me. What else do we need? I mean, asking for money is far too easy, but I think we need two additional elements. One is infrastructure, having machines. Here you have an example of a supercomputer that we have here in Liguria, but also machines for genomics, for sequencing, latest generation, and so forth is important. The other element is people. We need training. We need to train people to the use of AI. Our SMEs, this is Italy, there are at least more than 100,000 that need digitization at a decent level, and they need to know about ICT at a very deep level. We need more students, 5 times the students that are right now in computer science. We need to multiply that number by 5, and we need training also for workers to be able to use AI. If we manage to catch this opportunity, to seize the opportunity, we're going to have potential benefits amounting to something like 300 billion a year, which is 18% of our GDP today. So, I mean, we can actually compensate with this population that is decreasing or getting older. So, I wanted to say that indeed many roads of this scenario go through AI. Many thanks for having invited me, and let's have a good discussion during the work panels. Thank you.
Thank you, Professor Metta. Thank you.
The Organization for Economic Cooperation and Development, OECD, is an intergovernmental organization with 38 member countries. It was founded to stimulate economic progress and world trade. Stefano Scarpetta has been the director of the Employment, Labor and Social Affairs, ELS, Directorate of OECD since 2013. ELS provides continuous assistance and support to countries in the design, implementation and evaluation of policies drawing from evidence-based analysis, including the health agenda. Stefano Scarpetta will provide us with an overview of the aging process in OECD countries and with the evidence that investing in prevention is cost-effective.
Grazie, signor Ministro Schillaci, signor Presidente, signor Sindaco, autorità di questa bellissima città di Genova, della regione Sicilia. Dear representative from the G7 countries, let me start by saying that it's really a great pleasure for me to be here with all of you and to share some of the perspective of the OECD on this fundamental topic, lifelong prevention for a healthy and active aging. I think as Minister Schillaci recalled in his intervention, this is one of the crucial challenges, but actually one of the main opportunities, not only for Italy and for Genoa, but actually for all G7 countries, I would say for most, if not all, the OECD countries. I think the context by now is clear. The population in the G7 countries have one of the highest healthy life expectancies. And I think the example of the city of Genova is just one. I would like to underline healthy, because we're no longer living longer, but we're living longer in good health. Now, associated that with the declining fertility rate that also Giorgio Metta was showing to us, this of course means that population are aging, and this will certainly raise a number of challenges for health, for social, but also for our economies. Indeed, the statistics, I think, are well known by that. Italy is getting into sort of an autumn, demographic autumn, which will get quickly into a winter. The share of the G7 population 65 plus will reach 27% of the total population by 2040, and this represents a 22% increase given the level we have today. By 2040, 1 in 4 people in the G7 countries will be 65 and plus, and in some countries of the G7, including Italy and Japan, this proportion will be significantly larger. It goes without saying that this will bring a number of challenges for the healthcare systems, but also for the spending on health. Older people are significantly more likely to develop a multiple chronic condition. For example, more than 1/3 of them, 37% of those aged 65 plus, have on average 2 chronic conditions in the European countries. Our projection also showed that, and you can see that on the right-hand side chart in this slide, that public health expenditure in the G7 countries can increase by in between 1.5 and 3% a year in between now and 2040. And you can see also what is the contribution of the aging of the population to that. This represents on average 1/5 of the expected spending per year, but actually in some countries this can reach actually 50% of the total increase. What are the implications of that for our economies and for our societies? Here we run just a simple simulation, and which we show basically if nothing changes in the labor market, so basically participation rate and employment rate remain as they are today, this would imply that the GDP per capita can fall by almost 8% by 2050 as a result of the decline in the labor force, which is associated with the aging of the population. 4 of the G7 countries that are shown in this chart are projected to experience a decline well above the average of the OECD, with Italy experiencing, for example, the largest decline of about 17% of GDP. This is a very large number, but there is a but. Certainly we can do more and much more in order to promote participation, active participation into the labor market of the senior as well as women and young people in Italy, because we know that the employment rate of women and young people in Italy are still quite low. So there is a significant challenge which goes beyond the health sector that actually involves the employment and labor market policies to actually promote participation of all groups, active participation into our economies. I think Giorgio Metta gave us a fascinating presentation about the huge potential that digital and in particular artificial intelligence can bring in the health sector in terms of research and development, but also way beyond the health sector. One point I would like to underline in this slide is that we have run a survey on 2,000 companies using artificial intelligence, 5,300 workers in manufacturing, in finance, and actually we asked the employers, are you substituting artificial intelligence for workers? And the answer is that the vast majority of them, more than 50%, actually are not substituting workers using artificial intelligence. They're actually complementing the workers with artificial intelligence. More than 50% kept the employment constant, some increased employment, in some cases actually the employment declined. So far we don't see substitution, so we cannot count on digital and artificial intelligence to compensate for the decline in the working age population associated with aging. But there are a number of very important messages as well. I think Giorgio Metta showed the huge potential in terms of research and development. The other important point that was actually recalled by the mayor of Genoa is that artificial intelligence can make our labor market way more inclusive, can allow people with disability, with physical disability, to participate more actively, more fully into the labor market. And the other important point, and there is emerging evidence of that, is that in particular generative AI can actually vastly enhance the capabilities of workers, not the workers at the top end of the skill distribution, but workers with intermediate level of skills and competences. So they can do much more using artificial intelligence what they used to do in their job. So there is a huge potential to promote the inclusivity of the labor market, but also to enhance the productivity and the enjoyment of work by many, many workers. In fact, one of the interesting findings of this survey is that 4 out of 5 workers using artificial intelligence told that this actually not only improve their performances, they can focus on the most interesting part of their job, they can actually leave to the machine and to some extent the algorithm, the more dangerous and tedious part of the job, but this actually improve, because of that, the quality of the job, the perceived quality of their job, and reduce mental health. Now let me go to what I think is one of the core messages that I would like to deliver with you. We need to invest more on prevention. I think Minister Schillaci said that we tend to spend more and focus more on coping with problems, health problems. We need to invest more on preventing problems from arising in the first place. Investing in prevention has a significant positive impact on people's lives and on productivity. And investing in prevention also makes countries more resilient, and we see that post-COVID. However, excluding the increase in spending on COVID vaccination in 2021, even the G7 countries spend less than 4% of total health budget on prevention. And also, the prevention budget tend to actually be very sensitive to business cycle fluctuation. We see that during the financial crisis, where actually spending declined. We have seen that in more recent period. Actually, you see that on the left-hand side of this slide that OECD calculated the return on investment on policy strategies for major public health threats, including obesity, harmful alcohol use, antimicrobial resistance, which also primarily affect older population, have a huge return. You see some estimate that investing $1 in prevention in these areas has a return that varies from 1.7 up to $13.1 for every dollar invested in the case of reducing or tackling harmful alcohol consumption. So investment in this area makes a good economic sense as well as a good health sense. And I think certainly we have to find ways in which we can secure a significant part of the budget in the health sector to actually invest on prevention. So let me conclude with some general observation. There are many interventions that countries can use to promote healthier lifestyles among adults. We have heard some very good experience also in the case of Genoa. Counseling in primary care is effective in promoting healthier lifestyles, but is also expensive and place additional burden on primary care services, which are already under pressure, as we know very well also post-COVID. Community-based programs to promote active lifestyles for older people are effective in keeping people healthy and prevent social isolation, but also can raise issues of equity and affordability, because we know very well that lower income neighborhoods may not have sufficient resources to invest in community-based programs. Workplace-based intervention as part of the employee well-being packages also have a huge potential for getting growing interest into mobilizing resources from the private sector, for which they help improve productivity, but also attract and retain talent. But privacy, of course, also an issue that we have to take into account. So it is important to not just focus in one area, focus on prevention for sure, but within that to focus on a wide range of different measures, starting from the position of different countries and different communities, and see what are the areas in which the investment would have the highest return. So these are some of the observations I wanted to share with you, but I very much look forward for the discussion in these 2 days of this very important part of the G7 reflection on health issues. Thank you very much for your attention.
Thank you. Thank you, Professor Scarpetta. I don't know about you, Roberta, but now my understanding of these 2 key topics is way clearer. That's why, because then it's possible thanks to the presentations by 2 keynote speakers, and I would like to them with an applause with all the audience.
Now it's time to invite on stage the speakers for our opening session. Their presentations will be the perfect introduction for the 4 panel sessions that will follow today, this afternoon, and tomorrow morning. Please welcome with an applause Anna Maria Colau, William Coburn Salazar, Andrea Laghi, Marco Marcella, and Amira Guaibe.
Please. Okay. You can take a seat, please. Anna Maria Colau is Professor of Endocrinology and Metabolic Diseases and UNESCO Chair for Health Education and Sustainable Development at Federico II University of Naples. She is also Director of the Department of Endocrinology, Diabetology, Andrology, and Nutrition at the University Hospital Federico II of Naples. She's a top Italian scientist since year 2000. Professor Colau will explain what we intend for lifelong prevention and why it's important to apply it. Please.
So first of all, thank a lot for this invitation, in particular to the Scientific Committee and the dearest Minister of Health, Orazio Schillaci. It's a privilege to be today with you and to start the introduction of this meeting. We have already listened many different parts of my talk, because certainly just to honor Rita Levi Montalcini, we have been very good in extending life, so in adding days to life, maybe a little bit less in adding life to days. And we have listened that we have expectation of an enormous amount of people aged above 65 years in a very, very short period of time. So certainly it's something that we have to address in the best way we can, starting with the gestational age, the newborn, the early childhood, the school age, the working age, and the old age. There is always possibility to expand the strategies and the, let's say, protocols in a way, the methodology to make prevention. So there is, in any different age, the possibility to improve the strategy to counteract the trend toward developing chronic diseases. And I think that one of the most important points as an endocrinologist and an expert of metabolic diseases is the gestational age. Probably during this period we are missing something, because what happens later in life has been already programmed during pregnancy. So if we don't address in a more, let's say, accurate way the gestational age, probably we will have a lot of other problems later on. We have also said that there is a risk for natality in the future. So probably this is also very important for the future social activity in working years. And certainly overweight is one of the most important tasks we need to address, because there is a stopping in many different parts of the fertility program. And this is something that still needs some different way to be addressed. Firstly, because the gestational diabetes is a very risky factor for mothers and children, and is closely related to overweight and obesity. So probably one of the things we have to address a little bit more in detail that we are doing nowadays is obesity. On vaccination strategies, we have done quite a good job. We have many more vaccines today than we had even only 20 years ago. Probably we need to do even more education to our population to explain a little bit more in detail, which is the strategy for the vaccination. But certainly we prevented that for many different diseases. And one area to implement vaccination is certainly the sexually transmitted diseases. Now we are seeing back some diseases that were completely forgotten in the past 20 years. One is the syphilis, and the other one is gonorrhea, that are coming back. So probably we need to give some more education to the young adults, the adolescents, because they are not at all educated to these diseases. And again, this is a prevention strategy. To educate at school, to educate the adolescents is something that we need to do for the next years. Something about obesity has been already said, so I cannot repeat what you know and we have already said, but the increase in the obesity population all around the Western world is really something that should worry us a little bit, no? And even in Italy we have 10%, even a little bit more than 10% of population that is obese. And the most important part, in my opinion, is not just nutrition. We have many different protocols of nutrition that are very good, but it's the physical inactivity. Unfortunately, we are very sedentary, even in this room. We are all set. And let's say that sedentarity is something that is making all of us sick, even if we have a fantastic nutrition strategy. So we need to make some more exercise. And even in the, let's say, for age, that is the older population, we can make some prevention, because generally when we have overcome cancer and cardiovascular disease, the most important cause of mortality is the fractures. So we can reduce fracture risk with some program, a special program to implement bone strength and bone quality just in the middle age in order to reduce the fracture risk. That is certainly more women than men disease, but we have 20% of all fractures that are male gender and not female gender. So probably even in this setting, the education is very important. So this is something related to mental disorders that after COVID pandemic has really increased a lot, and probably even for the mental status that has been already said that health is not just something related to the absence of diseases, but this is more complex phenomenon that also include the good health of the mental part is something we can really prevent with a good quality of life and even sociality that should be improved. The European Council of the European Union certainly has already targeted many different areas. So with some challenge, some action required, and disease prevention. So there are many different programs already ongoing that probably we can implement or at least follows in a more detailed way. And so my sort of take-home message is not a conclusion because this is just an initial lecture, so we cannot conclude. But it's just that the active ages is a process optimizing opportunities for health, and indeed to add some life to our days. To promote the active aging, we need to improve education of the population, even before we start improving the healthy lifestyle, because without the education of the population, there is no prevention strategies that can be really successful. And certainly we need also to promote some primary prevention on stopping tobacco, alcohol, drug use and abuse, to implement vaccination, physical activity and healthy diet, but also some screening for the early detection of diseases and tertiary prevention for the management of diseases. So there is a big area to work on. I'm very happy that our Minister of Health has decided to implement the strategies for prevention, because this is exactly the way to pursue for future. Thank you very much.
William Coburn has worked at the European Agency for Safety and Health at Work, EUOSHA, since 1998. The agency is the EU reference center for promoting better working conditions. And Coburn, he focused on the areas of research coordination and emerging risks, and after some years as head of the Prevention and Research Unit, in 2023 became EUOSHA's Executive Director. Dr. Coburn will analyze now the main determinants of unhealthy occupational conditions, and will tell us how work is a key determinant for health and how important it is to invest in prevention at workplaces.
Thank you. Thank you so much. And thank you for the invitation for the EU Agency for Safety and Health at Work. And it's a privilege to be here and listen to the insightful presentations from the Minister, the other dignitaries, and the co-presenters. I think the selection of these twin pillars of lifelong prevention of risks and innovation is very insightful. It's very fortunate. It's one that also speaks to occupational safety and health, and it's so important as well that occupational safety and health is heard and seen in this context, as we saw the importance during the COVID-19 pandemic of the occupational setting when we're looking at public health measures. And occupational safety and health has a long history. In fact, just not so far away at the University of Parma, Bernardino Ramazzini, more than 300 years ago, first described the impact of working conditions on people's health, and he's rightly known as the father of occupational medicine. And over 200 years ago, we had the first legislation preventing risks to workers in factories, preventing child labor, and so on. Coming to more recent history, of course, we've got common legislation across the EU member states, one framework directive, 23 individual directives focused on risks, sectors or groups that set high common standards for risk prevention. But the situation is not great, it has to be said. If today was an average day in Europe, 10 workers would die from a work-related accident. 600 people would die prematurely from a work-related illness. In addition to that, there are millions of working days lost due to work-related illness, work-related injury, and that has an enormous toll, not only in terms of human suffering, but also in terms of the economy. The best estimates we have is that it's equivalent of 3% of GDP. And that's all the more important if we think now that we're in Europe in a situation where there's a severe shortage of skilled labour. So to be able to keep people in labour, to be able to keep people in their jobs healthy and productive is a necessary economic imperative, as we heard just earlier from the OECD. There are a number of risks, trends that have been identified by the EU that make this situation something of a concern. And the first one is the demographic transition, and that's identified in the EU Strategic Framework on Occupational Safety and Health. And we've already seen some statistics. What I'd like to highlight is that the latest Eurostat forecasts say that the next 10 years are the ones where we'll see the greatest changes. For the working age population, as we know it now, traditionally, 16 to 63, we'll see a 5% decline. That's 10 million workers less in our economy, equivalent to the working population of the Netherlands. So as we saw in the presentation from my colleague at the ECD, the impact is going to be quite dramatic. It'll be different according to the countries, not only as a result of birth rate, but as a result of migration from outside of the EU into the EU and within the EU as well. So the country that was identified as having the biggest drop in working age population is actually Slovakia. And as we age, of course, when we're at work, that means we're exposed to risks for longer. That means we're exposed to dangerous substances, to noise, to all sorts of risks, poor postures, sedentarism. At the same time, as we get older, we also have cognitive and physical vulnerabilities that increase, making us again more susceptible. And of course, we'll have more caring responsibilities. We may be looking after elderly relatives, after children, so there's increased psychosocial pressures on us as well. The second main challenge that is identified at EU level is climate change. And there we can differentiate risks arising from the direct effects of climate change, so high temperatures like we have today, particularly if you're working outdoors or in a hot internal environment. Also, we have a spread in disease vectors, so mosquitoes are carrying diseases like dengue, West Nile virus, to areas that were previously unknown and affecting the working population. And then we also have risks from the mitigation measures. So we're refitting buildings, we're refurbishing buildings, improving insulation, and that's exposing workers to asbestos. And that's one of the biggest causes of early death, work-related exposure to asbestos resulting in cancer. But there are also risks related to new battery technologies, photovoltaic cells, offshore wind. And the third transition identified at EU level is digitalization. And digitalization, if the work is not well designed, can carry with it many risks, whether that's remote working, leading to isolation and sedentarism, whether that's increased risk of accidents or so on. But it's not all bad news. With good preventive measures at the workplace level, all of these risks are preventable. What we need is a strong legislative framework, which we have, but backed up by good enforcement, good resources, guidelines, expertise, and resources at the level of the employer. And that's what we're working on at the agency. So talking about employers, they have the obligation under EU law to carry out an assessment of the risks that their workers are potentially exposed to, and then to take measures to remove those risks if they're detected. And those risk assessments are meant to be diversity sensitive. That means that they're meant to take account of the worker's variability. They're meant to take account of a worker if they have a chronic disease, if they have a disability. And the employer has to change the job, the work environment, the tools to adapt it to the worker, not the other way around. And when we have a safe and healthy environment, that makes it easier for all. It makes it easier also for healthy workers. And that's essential if we're going to make work sustainable, if we're going to keep people in employment, and we're going to have a productive society and one that is healthier and safer in the long run. So I hope that with that presentation I can bring in the perspective of the occupational safety and health, and I'm really looking forward to the discussions later today and in the rest of the event. Thanks again.
And now, Andrea Laghi is full professor at Sapienza University of Rome and director of diagnostic and interventional radiology at Sant'Andrea Hospital. He is also a member of Consiglio Superiore di Sanità, our National Health Council. In these last years, he has particularly focused his research interest in the application of AI in diagnostics. Professor Laghi will provide us an overview of biomedical innovations for healthy aging, the topic of the first panel of this technical event. Please.
Thank you, Mr. Chairman. And of course, let me thank first our Minister of Health for the very kind invitation. So it's a great pleasure and honor for me to share with you some ideas about opportunities and challenges of artificial intelligence in the field of imaging. There are three main areas of imaging where AI can have an impact. It means the process management, diagnosis and care, and education and research. And this profound impact will be even more profound with the development and the introduction of generative AI, which happened a couple of years ago. Nowadays, the multimodal foundation models, the generative AI, can improve clinical efficiency in radiology, but honestly in the entire medical world, because, for example, can generate automatic or semi-automatic reports, can help doctors in patient history summarization. I'll give you an example. This is an AI-generated health medical record from a patient where we have a summary in few seconds or less than seconds about what happened at that patient in the last 5 years. And I have a glance view of what's going on, and I can report my CT, for example, very easily. We can also improve communication between patient and doctors. So how difficult it is for a patient to understand a radiological report. That's a project we are running where we the patient send the PDF of the report into this AI-based software, and the software translates into common words a medical report, suggesting the patient if it is necessary he or she needs to take action concerning what is written in the report. But also, those kind of algorithms can help us, for example, in the emergency room, in pre-reading the images and showing the radiologists with a red flag what are the most urgent cases to be reported first rather than the others. Or if you want to enter into the world of precision medicine, this is really a patient-centric approach. You see this dot in the center is the patient, and all those circles represent the different big data concerning the patient. The bigger the data, the more important for the clinical history of that patient. So we can really personalize our approach to medicine. And finally, the integration of AI into business analytics or business intelligence software, not only to improve productivity, that's important for sure, but also to improve the quality of work, preventing the burnout of our healthcare personnel. And finally, they can help us also in creating intelligent work lists and monitoring appropriateness criteria. So the second area is diagnosis and care. Here we have products already available in the market. Probably most of you do not realize that there is an invisible AI which reduces the dose exposure for the patient in CT by 60% or reduce the time examination for MR by 50%, increasing patient comfort. There is also a visible AI helping radiologists with simple diagnostic support system, automatic detection of bone fracture, automatic detection of finding in chest x-rays. Then there are the more complex systems in oncology, predicting the response to therapy. That's a very important task, but you need in that case a complex system, a multimodal system, a multi-omics system, and of course there are European projects working on that. Or in health prevention, for example, AI can extract data about body composition from a CT, for example, providing the cardiovascular risk for that specific patient. And in education and research, the last point, of course, virtual reality can help our interventional radiologists in my field or surgeons to be better trained with low patient and low operator risk, and also reducing the cost. And large language model, as you know, can help also researchers in writing scientific papers, bibliographic research. Of course, there are some issues that need to be solved about ethical and legal issues. Those are the opportunities. But all that glitters is not gold, because there are also challenges. And there are challenges at different levels: infrastructural level, regulatory ethical level, local management level, personal level. I have no time to go through all of them, of course. I pick up only the professional level. There is a digital gap of the healthcare professional. It's true. I'm a doctor. I have a digital gap because of poor knowledge, because of distrust and self-referentiality. I'll give you an example from my hospital. I implemented the software for bone detection, bone fracture detection 2 years ago. And after 6 months, only 20% of my radiologists were using the software, missing a clear fracture. I think all of you can see this fracture here, missing because it was reported at 3 a.m. in the morning after a polytrauma. Because what the radiologists, they do not understand, probably an expert radiologist is better definitely than AI, but the performances of an AI software are constant, whereas the performances of radiologists or the doctors fluctuates over the day because of different external events. So why don't we be scared about AI? Well, prediction about the disappearance of radiologists failed, you know. What is clear now is that AI will not replace our job, but radiologists using AI will replace radiologists who don't use AI. That's clear. That's the message that should come from this consensus. Because I don't want to spend an entire morning reading a chest X-ray or a chest CT to find a small nodule in the lung. That task, an easy task, can be better and faster performed by a computer. What I want to do, I want to save my time and spend more time on a multidisciplinary tumor board deciding about the outcomes of a patient. Because science and AI, if you wish, can make predictions, but they cannot take decisions, because decisions are human. And let me conclude with this editorial, which was published in JAMA in May 24, so two months ago. And read together. Industry will foster the necessary technical developments, whether medical men take part or not in the computer revolution. Invention will transform our lives and our society. Revolution in our ability to interpret medical observation. Is it referred to AI? No. It was written in 1964. It was referred to the first computers entering into the medical world, but you can apply those kind of words exactly today. The point is that we, as doctors, need to drive the process, because if we are not at the table, you are on the menu. Thank you.
Thank you very much, Dr. Laghi. Now, Dr. Marco Marcella, who is head of the e-health, well-being and aging unit at the Directorate General for Communications, Networks, Content and Technology. We used to call it DigiConnect of the European Commission. He's worked on policy development, innovation, and research implementation in the areas of digital content, technologies for learning, e-inclusion, and assistive technologies. Dr. Marcella will discuss the role that European Union, place in policy making in relation to AI and health.
Thank you very much. So first of all, let me join my fellow panelists in thanking the Presidency, the Minister, the authority, by the way, organizing a meeting in such a splendid cornice, I would say in Italian. So thank you, and thank you for the opportunity to elaborate a bit on the approach that the European Union is taking in this important subject. So thanks again for having raised that at the Presidency level, both for inviting us to bringing up the topic, but also taking up tomorrow that aspect. So it is the element of aging in Europe, but also in other regions of the world is clear. And we are working towards essentially extending lifespans, but the responsibility is to extend that lifespan not only for longer lives, but also for healthier and better lives. And the point here is, how does technology help in achieving that objective? And let me elaborate on some opportunities, on some challenges, and on some actions that we are developing together with the member states at European level. So first of all, and we have plenty of examples that digital does have the opportunities to improve our life for several reasons. The quality of life of citizens, of patients, and it includes the possibilities for improving the inputs that citizens may give to the economy. So the concept of participations. Now we know and we saw some spectacular examples of assistive technologies, of sensors, of telemedicine solutions, and how they can participate in creating an environment that is essentially empowering the citizens to take what we expect to be an active role on their health life path. Now, this technology certainly will help in creating environments that support independent living, which, by the way, it is one of the aspects that we put forward. We heard this morning or before on helping also on mental health solutions. Now, it helps. So the second opportunity, it is also in, let's say, the forward-looking examples in helping healthcare systems in deploying solutions that go towards preventive and personalized approaches. Early detections, we heard, predictions on high risks of non-communicable diseases. Now, all this is rounded around data-driven approaches. So understanding even the determinants of health, they are strongly rooted in our ability to collect the data, analyze the data, and generate insights out of it. And the third opportunities that we have, it is in relation to the sustainability and the efficiency of healthcare systems per se. We know that the technology we heard about telehealth and telemedicine can improve access to high quality and affordable care services, but they can also alleviate the burden, the administrative burden in hospital settings, and therefore reducing the costs that are attached to delivering healthcare solutions. Now, there are challenges, and there are challenges of different dimensions. Let me analyze some. So, well, first, we do have a wealth of health data that is generated in our systems every day and throughout different environments. Now, we realize that if we manage to leverage that data, we can develop that technological solutions that would help transform health and care. Now, to fully do so, we need to address a number of elements. So first of all, we need to provide the citizens, the workforce, patients, citizens, access to health data. The possibilities of accessing, but also the possibilities of controlling it for full reuse. Now, in Europe, and this is one of the initiatives that I would like to talk to you about, the European countries, the member states, they are developing a regulation which is called European Health Data Space. The European Data Space, it is a unique set of regulations because it will allow the roaming of health data in Europe seamlessly. It will allow a secure exchange of health data between countries, and it will empower the citizens to control access to their health data. And in addition to providing control, it will also enable them to decide with whom they want to share for their data, and it will create the conditions for the reuse of health data for research, for technological development, and in general for innovation. Now, that kind of regulations which will be enacted towards the end of this year has at its basis, at its root, trust. You know, if we don't have a trustful environment, forget about the innovation environment. Now, in addition to creating, say, the regulatory space for trustful use of data, you also need, as we heard this morning, health data infrastructures. And in that sense, the European Commission, it is supporting the member states in developing health data infrastructures, for instance, like cancer imaging that we just heard, but also the genomic initiative and the virtual human twins. For instance, in the context of the 1 Million Genome Initiative, this genomic data infrastructure will provide secure access across border to more than 1 million genome, which will pave the way to our personalized medicines approach. Now, the second challenge that we have, it is in making sure that we do harness the power of artificial intelligence that will use that data in a way that it creates safe development and safe deployment of these products and services. And that takes me to the second initiative that I wanted to briefly highlight to you, and that is the European Union Artificial Intelligence Act. That is the first framework worldwide that sets the legal underpinnings for the development and use of trustful artificial intelligence for the protections of public interest in the European Union. Now, let me conclude by highlighting that this perspective of putting data and artificial intelligence in a work that is synergetic, you know, that synergies, it is essential for the delivery of the solutions that we are hearing today. And, you know, and let me say that the first perspective that we have to keep in mind in developing this technological solution is that we need to build and maintain both the citizens and patient trusts into the systems. Trust is a critical component, as we've heard, in healthcare systems, and we need to have the strategies and the best practices for fostering trust among the actors that we are working with. So patients, caregivers, healthcare providers, researchers, and policymakers. Now, this is the reasons why trust is at the core of the activities of the European Union, part of the European Health Data Space, part of the AI Act. But the second perspective is that we cannot do that in isolation. This requires collaborations beyond Europe, collaborations at regional and global level, and that is yet another reason to thank the Italian presidency of G7 to take that element today for discussion. So thank you very much, and looking forward to collaboration.
Thank you, Professor Marcella. And now we have Dr. Amira Ghwaibi, is head of Women's Health at the World Economic Forum, and develops programs to focus attention on the most urgent questions and initiatives in the field of global health, women's health, science and innovation, sustainable financing of care, healthcare, and more. She has more than 15 years of experience in the global health field and of healthcare. Dr. Ghwaibi will provide us with a point of view on the aging based on gender and tell us more about the role of the World Economic Forum and of civil society in general in this field. Please.
Thank you. Thank you. G7 Presidency, honorable representatives and delegates, good afternoon. It's a pleasure to be on stage today, and I would like to thank the G7 Presidency for giving us the opportunity to address the important topic of women's health as part of the healthy and active aging theme. After all, it affects a bit more than 4 billion people globally. As mentioned, I'm Amira Ghwaibi. I'm the head of the Global Alliance for Women's Health that is hosted at the World Economic Forum. The World Economic Forum is an international institution that promotes public-private partnerships. In other words, we bring together the right stakeholders around the same table who have the will and power to move a specific agenda and topic. And in this context, I would like to thank our partners for the valuable contribution in moving this agenda forward. Paula Belostas Muguerza, who is the Global Head Healthcare at Kearney, and Carla Victoria Meira, who is the President at Athena Donna Foundation. We are only able to move the dial if we unite and move forward together. So I would like to start the presentation by breaking a myth and a misconception. We all agree today that indeed women live longer, but our study shows that women live 25% more time in poor health and with degrees of disability. A woman will spend on average 9 years in poor health, affecting her ability to be present and productive at home, in the workforce, and in the community, and as a consequence, reducing her earning potentials and economic opportunities broadly. And when we look at the women's health gap, and by women's health gap we mean the gender equity in healthcare between men and women, it actually corresponds to 75 million years of life loss due to poor health or early death per year. And to promote healthy aging, we must consider the health specificities of women and address the women's health gap. And we do that by looking at female-specific conditions, endometriosis or cervical cancer, or conditions that affect women differently, heart attack, cardiovascular diseases, or conditions that affect women more intensely, autoimmune conditions or Alzheimer's are good examples here. And this is where it is very important, as part of the theme today, to approach healthy and active aging by looking at the health span rather than the lifespan, and emphasize the importance of not only living a long life, but also adding healthy and productive life. Now here's the good news. Our studies show that closing the women's health gap could boost the global economy by $1 trillion per year. This is an economic opportunity of $530 billion for the G7 countries. And in terms of health span, this would add up to 7 more healthy days of life per year per woman. Now, let's try to understand what are the different factors and the causes for the women's health gap. And we need to start by recognizing that tackling women's health means understanding that women are not simply smaller versions of men and that their biology is uniquely different. And study shows also that the health span of women are affected by hormonal declines and changes, but also giving examples of brain health, heart health, or bone health. But it's also important for us to recognize an interesting fact, because the health disparity impact indeed women at all age, but it has been demonstrated that more than half of the women's health burden is actually happening during the productive years, between 20 to 60 years, impacting earning potentials for women. And Kearney and the Forum published earlier this year 2 distinct reports that actually have identified 4 different root causes for the women's health gap. And they are the research and innovation. We need to increase research when it comes to the female biology, as it's not well understood. The funding, women's health is underfunded. For example, just 4% of all biopharma R&D spending are actually allocated towards female-specific conditions, only 4%. Data only give us part of the story here, and the women's health burden is actually consistently underestimated, and many female-specific conditions are undervalued, depriving women for the attention and funding that they deserve. And the last piece is around the care delivery bias. Women will face barriers to care and will less likely receive effective and timely treatment and care. So from a woman's perspective, this translates to women seeking care and not taken seriously, misdiagnosed or diagnosed later. A woman won't be able to access adequate and quality solutions simply because no research and development has been prioritized and funded. So now that we understand the different causes and the factors of the women's health gap and the challenges that women are facing, what is it that we need to do? What are the actions and the solutions that need to be put in place? And this is really in this context that the World Economic Forum has launched earlier this year in Davos, the Global Alliance for Women's Health, that has a unique, ambitious goal, which is to close the women's health gap. And we do that with key partners. The alliance is co-chaired by the Gates Foundation and the Health Minister of Brazil, and we're bringing together different partners, communities from the public and private sector to help us moving this forward. And we have identified 3 different priorities, and I will go quickly through them. Financing. We need to unlock new investment and financing mechanisms to close the funding gap in women's health. We need more science and innovation so that more support and progress happen, so that women have the right solution when it comes to their own specific challenges. And the last piece is around the agenda setting, and we've proven with the 1 trillion opportunity, the more you invest in women's health, the more you are able to increase the GDP of your country, so that it also benefits women, families, communities, and societies. So I will close my presentation with a call for action to everyone and asking the G7 countries and other representatives to join us on our mission to close the women's health gap and allow more women not only live longer, but also have healthier lives. The more we invest in women's health, the more it benefits everyone. Thank you.
Thank you, Dr. Amira Guaibi. And thank you for being with us. Thank you. And now we can start with the first panel dedicated to biomedical innovation for healthy aging. And I'd like to introduce next relators. I'd like to have here on the stage Professor Antonio Uccelli, Professor Angelo Ravelli, please take a seat, Professor Rocco Papalia, Professor Gino Gerosa, Professor Paolo Durando, and Professor Laura Cancedda. Okay. Nice to meet you. We can sit, please. Because if we look back in time, we can understand the progresses that have been made in medicine. And the kick-off video provided some practical example of that. This panel will expand on this by presenting some of the most recent biomedical innovation that are driving advancements to foster healthy aging. Leading experts from different fields will share their research and insights on how these advancements can contribute to prolonging health span, improving quality of life, and preventing age-related diseases. The discussion will cover a range of topics from neurological and musculoskeletal disorders to pediatric and cardiac health, highlighting the interdisciplinary nature of innovation in this critical area. So, I think it's time to start with the first relator, who is Antonio Uccelli. is full professor of neurology at the University of Genova. Yes, you can go. And scientific director of San Martino Hospital that recently celebrated a 100-year of activity, a so-called IRCS, those institutes that excel for treatment and research. Professor Uccelli, based on your professional expertise, can you tell us which are the main opportunities offered by innovation in the area of neurology and mental health in order to improve disability life expectancy and to reach healthy and active aging?
Well, thank you very much. I think it's a difficult question. I will try to provide you with some examples in order to see how we can have an impact in terms of innovation on neurological disorders, with particular attention to those that are having an impact on disability occurring in late stages of our life. So, and I would like to say that if I need to summarize, I would see at least 3 opportunities, probably many others are available, but talking about neurodegenerative diseases, I think that one of the areas in which major investments are done by, for example, the IRCCS health systems, but also by industries, is in the field of identification of biomarkers for diseases, neurodegenerative diseases, or particularly for dementias, Alzheimer and other type of dementias. And I think from this point of view, we have the opportunity to take advantage of innovations in the field of imaging, MRI, PET, and other type of imaging, together with the identification of novel biomarkers in the field of, I would say, biochemical compounds, omics, proteomics, genomics, and all these are possibly allowing us to identify, as I said, biomarkers that would be optimal to have an impact on the prodromal phase of diseases such as Alzheimer, or in the early phases. And just to give you an example, the ability to identify those biomarkers that can be can let us able to diagnose Alzheimer or other type of neurodegenerative disorders in the early phase, or even in the prodromal phase, would allow us to give patients or individuals with some innovative therapies. This is one point. The other one that I would make, and I've been somehow already touched, would consider the opportunity to use multimodal data. What I mean for multimodal data, there are collected from different sources, again, images, omics, anagrammes, insurance, that can be put together to build up what they are called the so-called digital twins. And for what it's our understanding, I would talk about brain digital twins that can be used for modeling, for example, for prognostic reasons, or for the identification of pharmaceutical targets for new therapeutics, or to make predictions for, as I said, prognostic factors for the development of diseases or the worsening of disease or response to therapies. And the last example I make, which is again pretty much focusing on new technologies and innovation, I would say that one of the best innovations we had in the field of neuroscience is related to the ability to work on the so-called brain on a chip. What is a brain on a chip? Is an organoid or a brain that we can somehow generate in the lab in order to, and this can be done from the cell of a single patient, so we can somehow generate a virtual brain that represents that single individual, and that again can be used to either get information how it functions, or even as a model to predict the possibility to have optimal therapeutic responses to new drugs. So all these are somehow very innovative approaches and just examples, as you may imagine, that can be used for neurological diseases and particularly for neurodegenerative diseases occurring in the late stage of our life. Thank you.
Thank you, Professor Uccelli. And sorry, it's my mistake because I told you to go there, but you can sit here. No, you can sit here, close to me, and we can continue. Stay sitting here. Thank you. Yes, here. And now Angelo Ravelli. No, you can stay here. So, thank you. He's full professor of pediatrics and scientific director of Gaslini Institute here in Genova. Another IRCS, worldwide reference for maternal and child health. Professor Ravelli, based on your expertise, can you tell us about the main risk factors that affect child health and some of the most relevant innovations for the prevention of diseases in children? Yes, you can speak here. Don't you have the... non abbiamo il microfono, scusate. Okay, now it's coming, don't worry. You can relax.
Okay. Good. Thank you very much. Let me first say that I feel a bit misplaced in this meeting because I am a pediatrician, but as you said, besides being one of the eldest regions in the world, the Liguria region hosts the Gaslini Hospital, which is one of the two largest children's hospitals in Italy. So regarding your questions, I would first emphasize that in the last few decades, there has been a relative increase in the prevalence of some chronic disorders which include metabolic conditions, particularly diabetes and obesity, cardiovascular illnesses, inflammatory autoimmune diseases, and also malignancies. It is increasingly realized that many of the risk factors for these conditions are already present in the early years of life, and they continue to have an impact all along the life of each of the affected individuals. So, based on this notion, it is clear that recognizing the risk factors already in infancy and tackling this risk factor in the early years of life may help to prevent the occurrence of this dreadful condition, which, as we know, pose an important burden to the national healthcare system. At the Gaslini Hospital, we have won a grant which was from the Ministry of Health, which was named, and the Ministry of Health will fund a project named Life Map with more than 5 million euros. So this project, for which the Gaslini is the leading center, and the Gaslini gathers 11 research units all over the country. So this project is very ambitious because it is aimed to try to identify, by evaluating a very large population of more than 5,000 individuals with the conditions that I mentioned before. These patients will undergo genetic testing and the assessments of the lifestyle and of the other environmental factors which may affect the occurrence later on of the chronic conditions that I mentioned before. And these factors will be coupled with clinical data, history of the patient, and assessment of the environment in which these patients live. And all these data will be combined and analyzed with artificial intelligence methodologies with the aim of developing, let's say, integrated models of risk factors that may predict the occurrence of cardiovascular, metabolic diseases, malignancies, autoimmune inflammatory disorders. And the identification of these models, of these trajectories, will potentially serve to make the necessary intervention by correcting lifestyles, for instance, wrong habits, or trying to make other form of prevention with the aim of avoiding that these subjects could develop in the adult life the disorders that we are studying.
Thank you. Thank you, Professor Ravelli. Thank you. And now it's time to listen Rocco Papalia. He's a full professor of orthopedics at the Campus Biomedico University of Rome, a center of excellence in this field that has been inaugurated by Professor Vincenzo Denaro. His main area of expertise is related to prosthesis surgery, and we all know how this field has already improved dramatically the quality of life for elderly people and not only for them. Professor Papalia, can you tell us about the current orthopedic prosthesis and the impact that they have had for an aging population as the Italian one?
Thank you very much for the question. The osteoarthritis is a result in less mobility. And then osteoarthritis is one of the most frequent degenerative conditions worldwide that reduce the quality of life of patients around the world. In the past, we had not treatment for this kind of condition, but now the technology is advanced, before all in joint replacement surgery, and then especially for hips and knees. And then we have the possibility to have a revolution in mobility and prevention of the degeneration of movement in this kind of patients. And joint replacement surgery not only restores the mobility, but also improves the total well-being. And then this kind of patients, elderly patients, suffered from joint stiffness and pain can be pain-free and come back to very good life with improvement of mobility and also enjoying social activities. Deciding on a joint replacement surgery involves careful consideration of factors such as global health and joint replacement, and also functional limitation of the patients. But nowadays, the recent advances in joint replacement surgery and also the anesthesia procedures and other conditions like post-operative care have improved the outcomes even in elderly patients that nowadays could be active managing health pathologies, multiple health pathology. And now joint replacement surgery improved the outcomes and with the high rates of satisfaction of the patients and good return to high lifestyle, also including work and sport. A new technology is related to robotic-assisted surgery. This technique is based on the precision and also the personalized surgery. Now we are able to tailor our surgery for each patient's anatomy.
The first improvement is an intraoperative improvement that is related to fewer complications and also minimal tissue damage. The postoperative improvements are related to short hospital stay, quick recovery in these patients, and also minimal postoperative discomfort. And then the joint replacement surgery combined with robotics procedure now is related to high quality of life and quick recovery in the patients, in Italian patients. And as we have seen in the video before, we are able today to give the possibility to elderly patients to be active free of limitation of osteoarthritis. Thank you.
Thank you. Thank you, Professor Papalia. And now Gino Gerosa is full professor of cardiac surgery at the University of Padua and former president of the Italian Society of Cardiac Surgery. He has implanted for the first time in Italy a total artificial heart. Professor Gerosa, cardiovascular diseases are one of the main causes of death and disability worldwide. Based on your expertise, can you tell us about the perspectives for innovation in this field?
Thank you. Good question. I think we could take one full day for discuss this topic, but let's try in 5 minutes to give you an answer. So, no doubt that primary prevention could successfully solve the burden, or at least reduce the burden of cardiovascular disease. I'm not forgetting that I'm a cardiac surgeon, so I should take care of repairing structural defects of the heart. So we can take the so-called secondary or tertiary prevention, and mostly tertiary prevention. That means providing the patients with the best solution, surgical solution, in order to solve this problem. Nowadays, of course, we are very used, and my colleague before was discussing about this, we are very used to post-op rehabilitation and things like that. But we can try to raise the bar and talk about prehabilitation in order to try to treat this patient far in advance than the surgical operation. And also we can take advantage of the so-called ERAS trajectories in order to grant the faster extubation, earlier demission from the ICU, early discharge from the hospital, in order to regain a better mental and physical health status. And how we can do that as a cardiac surgeons? Well, back in 1953, that was a big bang for cardiac surgery. John Gibbon, an American surgeon, actually for the first time repaired a structural defects of the heart, being able to open up the cardiac cavity using what we call at the time the bomb, the cardiopulmonary bypass. We then evolve and we move from standard cardiac surgery, that means the full sternotomy, the use of cardiopulmonary bypass and cardioplegic arrest, and we try to develop the so-called minimal invasive cardiac surgery. That means the ability to assess the heart and the cardiac cavity, not through the full sternotomy, but through small access, for example, mini thoracotomy, but still using cardiopulmonary bypass and cardioplegic arrest. And nowadays, I'm very proud of that. We developed this definition of microinvasive cardiac surgery at the University of Padua. That means the ability to repair structural heart defects, not only through a small incision, but avoiding cardiopulmonary bypass and cardioplegic arrest of the heart. In other words, to repair the structural heart defects off pump on the beating heart, using what we call the BiTech solution. What is BiTech solution? We can define BiTech solution to use whatever the innovation can provide us, the technical innovation can provide us, and using that innovation to modify our surgical techniques. And it means using transcatheter techniques, for example, or other devices that can allow us to do those operations on the beating heart without opening the cardiac cavity. And therefore, if you are successful doing that, and we are already successful in doing that because we are doing a lot of procedure with the microinvasive cardiac surgery, we are pretty happy because we are agreeing with Karl Popper, the philosopher of science, and it's the open society and its enemies. That means that we have to evolve, because if we are evolving, we are not perishing. And also, and I believe this is more important because I have a strong feeling with the ethics, I think we are also in accordance with Robert Sider and this paper. The title is The Ethics of Therapeutical Modality Choice. That means that as a professional, we can provide our patient with the entire platform of surgical strategies: standard cardiac surgery, minimally invasive cardiac surgery, microinvasive cardiac surgery. And in that way, not being biased. So we will be unbiased in order to provide and to offer to our patients the best surgical strategies and what we call personalized medicine. Thank you.
Thank you. Thank you, Professor Gerosa. And now, Paolo Durando. Paolo Durando is full professor and director of the Postgraduate School of Occupational Health at the University of Genoa and director of the Occupational Health Unit at the San Martino Teaching Hospital. Recently, he focused his research activity on strategies to improve the health and work capacity of workers living with disabilities. Professor Durando, we have been talking about biomedical innovation in different clinical areas: neurology, pediatrics, orthopedics, cardiology. Considering your expertise, can you tell us more about the main innovations in the field of occupational health?
Thank you. Good afternoon. Thank you for the introduction and for this question. But first of all, let me thank Dr. Salazar from the UOSHA for citing Bernardino Ramazzini, the father of our medical discipline. In this short talk, I have the opportunity to share the evolution of occupational medicine, of occupational health, from the traditional concept that we only have to make the environment, the work environment safe and to protect workers from hazard and from risk present in the workplace. But we have to do something more. Nowadays, the fundamental objective of our discipline is the adaptation of work to humans and of each worker to the specific task. That is a more complex objective. The idea is to place and maintain workers in an occupational environment that is perfect for physiological and psychological capability of the worker in order to prevent occupational disease, occupational injuries. We well know, unfortunately, that some of these injuries are fatal. 1,000 a year in 2023 in our country. This is not more acceptable. But also we have to promote and maintain the highest degree of physical, mental, social well-being of workers in all the occupation of our society. So we have a great opportunity in our country, in G7 countries, because you know that occupational health surveillance programs that in Italy are mandatory by law monitor millions, 20 millions in Italy each year of workers continuously. So in this view, we can monitor the health, improve, promote health lifestyles we saw before, and not only reduce occupational risk, but also promote well-being and work balance for a better society. During recent years, first in the United States by the NIOSH with the total worker health model, and also more recently in Europe and also in Italy. We know that we have to approach work in a more complex manner and to match the need of a good work and good and also better lifestyle of our workers. What about innovations and health at work? Well, we have to consider that new technologies, also digital technologies, we have seen smart working, remote working during the pandemics were helpful tools to reduce the exposure of workers to health risk. But also, to cite some few examples, the novel vaccines against SARS-CoV-2 during the pandemic also were really important and are example of biomedical innovation. We talked before about digital sensor in a smart device, not only to prevent occupational disease and prevent injuries, but also for risk assessment. I think that all these innovation, technology, digital technology, robotics, can help and can support occupational medicine to reach our objective for a better society. Let me, another concept that is more important, we have to focus on healthy workers, but we have also to focus on those workers. Aging workforce is a problem, and we have to manage it, but also we have to manage workers affected with chronic disease causing disabilities. I think that supportive technologies can help us to obtain our important objective. Thank you for your attention.
Thank you, Professor Durando. And now, Laura Cancedda received her PhD at Scuola Normale Superiore in Italy. She did her postdoc at University of Berkeley in California. In 2006, she joined the Italian Institute of Technology as the principal investigator of the Neurodevelopment and Disease Lab. Dr. Cancedda, we have learned about the challenges for the elderly in the neurological field. Can you tell us more about the importance of brain health and what happens to it with aging?
Okay, so thank you. Thanks for the introduction and for the invite. So let's get a step back and let's first all agree on what is the brain. So the brain is an organ like the heart, the lungs, the kidney, and as all organs has the function to promote the survival of the organism. But the brain is a special organ because it has another function, which is to promote the welfare of an organism. So if you have a fully functional brain, you should feel well. And this is really important because in the last 20, 30 years, I think that medicine has really improved a lot, and the survival of people has increased of a big number of years. But the problem has been that this longer survival of people has not been accompanied by an equal number of years that can be spent in a healthy way. Also because of the lack of the same progress in the study of the brain. So basically, elderly people undergo, all of them, a progressive degeneration of brain function, and those include problems with cognition, problems with motor, and problem with sleep, and also, as we heard already, and increased chances of being diagnosed with neurodegenerative disorders like Alzheimer's, Parkinson, Huntington disease that we all heard about. So what I wanted to highlight in these few minutes is now also the need not only on focus of neurodegenerative disorders that of course are really a burden, but also on healthy aging, because neuronal degeneration is present in all the aging people, even in the absence of neurodegenerative disorders. And this degeneration of brain function, even in healthy people, is basically accompanied by a loss in cognitive function, as we said, motor function and sensory function. And among the motor function, we're all very familiar with problems in retrieving and acquiring new memories, problem with word choices, slowness in thinking, and difficulties in multitasking. Now, the point is all these minor problems are very often accompanied by the stigma and the shame of growing old. And even if people with this problem can have a fairly healthy life, can survive many years, the shame that accompanies these problems, if you think of somebody that has been told something and doesn't remember, or somebody that doesn't hear very well, those people will most likely start to get isolated by themselves, will isolate them, and then will undergo to social isolation, potentially psychiatric problems like depression, eventually may also end up being recovered in nursing institutions. So the point is that if we promote brain health in aging, we'll try and will possibly achieve to turn the health of those people that sometimes are considered as a burden into something that can be treasured by everybody, because they do carry a lot of experience and knowledge. Thanks.
Thank you, Dr. Cancedda, thank you. Because we have another round of questions, so I want to start again with Professor Uccelli. As the scientific director of the San Martino Hospital, an institute of excellence for treatment and research, which role could have the so-called IRCs in the field of innovation?
Well, this is quite a challenging question. I mean, IRCs is a network of 54 research hospitals that and some of them are public, some of them are private, with a quite unique mission to provide to citizens the best care, health care on one side, combined with a deep commitment toward research, and particularly not fundamental research, but translational research. So the research we are expected to carry out is research that has a clear impact on health of citizens, and at the same time also on and talking about innovation, this is, I think, quite important, the opportunity to innovate in managing and programming our, the way we do care of patients. So new management of health system and epidemiology, and new models that can be provided to better improve patients' care. At the same time, one of the peculiar feature of IRCs is the fact that they are involved in a number of networks that are combining institutes that are particularly excellent in specific areas, oncology, hematology, immunology, neuroscience, cardiology, and those create the so-called reti di patologia, pathology networks, that are committed to establish not only research programs, but also the possibility to generate new ways of doing research that can translate into things as I said, novelties and innovation that can be applied directly to patients. And this possibility to share techniques, to share samples, to share methodologies among institutes that are spread all over the national territory, I think is quite a unique opportunity that is quite typical of Italy, and I think that it's something that is extremely important for the national health. I want to say, although this is not always the case, that in many cases, not all, ERCCS are also the place where there is university sites, and this makes the opportunity to combine both the strength of the health system together with the strength of the university to get the best out of it in order to, as I said, directly and immediately translate it to patient health.
Thank you. Thank you, Professor Uccelli. And Professor Ravelli, we have been discussing on the importance of life course prevention since early childhood. What can you tell us about neonatal screenings, and what kind of perspectives might be happening in this field?
Neonatal screenings?
Yes.
So let me start highlighting that the introduction of neonatal screening has been one of the major progresses in the field of medicine. But why these screenings are important? They are fundamental because they enable to identify, to diagnose potentially serious conditions immediately at birth, and then to treat with the medications that are available. And there has been in the last years a sharp increase in the novel medication that can be used to treat rare conditions for which there was no possibility of cure until a few years ago. So so the early treatment of this condition can help to prevent not only the mortality, because many of these conditions are fatal already after a few months or few years after birth, but also to avoid some of the serious non-reversible damage in various organs, including the brain, the heart, the kidney, and others that may develop if these diseases are not recognized and treated. Let me also say that Italy is probably among the various European countries the one which has the most advanced politics for neonatal screenings. And nowadays, more than 40 rare diseases can be diagnosed through the neonatal screening. So and also on top of that, all screenings that are now mandatory and also can be made entirely for free. So there are no costs for the family, in Italy at least. So now there is also a further progress which is taking place and is aimed to, let's say, to go from the simple biochemical testing made on dry blood samples taken from the neonatal, the heel of the neonate, to molecular screening, that is by searching through the analysis of the DNA of the child the presence of mutations which are associated with some of the serious hereditary genetic disease that nowadays cannot still be identified through neonatal screening. But there has been a progress recently, particularly at the Gazzini Institute, because we have introduced the new neonatal screening for two very serious diseases, the spinal muscle atrophy and severe congenital immune deficiency. The first condition leads to progressive rapid impairment in skeletal muscle, and these children, if untreated, die within a few months after birth, usually due to, let's say, irreversible impairment in respiratory muscles. And children with severe combined immune deficiency are susceptible to develop serious infections very early after birth, which may also be fatal. So nowadays, there are new therapies, novel therapies for spinal muscle atrophy, but also for severe combined immune deficiency, which is amenable to treatment with early bone marrow transplantation and other interventions. So at the Gazzini Hospital, we have introduced this new neonatal screening, and Liguria region for these screenings is the second for SMA and the third for combined immune deficiency. And so we are among the first regions in Italy to introduce these screenings. So, and we have already tested more than 23,000 children, let's say tested in all neonatal units of the Liguria region, and we have already identified 5 affected children in a few years, so which are now being treated and have had a sharp improvement in their quality of life in the course of their disease. So finally, what is let's say, looking at the future, could be the future of neonatal screening? So there is now a discussion and also a movement towards potential introduction of genomic screening. That is, we would evaluate the entire genome of the patient to look for all mutations potentially associated with the disease that are hereditary and have a genetic basis. However, this approach is still discussed, is still debated, because it involves important organizational, financial, and perhaps more important, ethical issues.
Thank you. Thank you, Professor Ravelli. And now, Professor Papalia, you have discussed about the orthopedic prostheses that are currently being used. Now we want to foresee the future. What's in it for the field of orthopedics? How can people recover better from disabilities?
Oh, thank you for the question. We are experiencing a transforming era from moving from orthopedic joint replacement surgery to regenerative medicine. And then now we want to treat the patient in another way, using regenerative medicine for osteoarthritis, for spine degeneration, as well as for bone defect. Regenerative medicine is very important in our field. Professor Denaro, that is here with us, was a pioneer of regenerative medicine, and 25 years ago, he encouraged us to visit and to travel and to go in other centers around the world to be updated in novelties in regenerative medicine. This method was very good because it was a booster for Fondazione Policlinico Universitario Campus Biomedico to do regenerative medicine, and also because now Italy is at the forefront of regenerative orthopedics. Regenerative orthopedics is based on the natural ability of healing of our body, and also the ability to regenerate tissue damage. For example, one example is the use of mesenchymal stem cells that could able to transform into other tissue, as bone, as cartilage, as intervertebral disc cells. And we at Fondazione Policlinico Campus Biomedico, Universitario Campus Biomedico, we received several fundings. We won several awards for the research to carry out clinical trials in these fields. One of these projects was for stem cells, mesenchymal stem cells, that are able to transform in chondrocytes to treat the osteoarthritis with promising results for the elderly patients. Another trial was about injection of mesenchymal stem cells in intervertebral disc degenerate with promising results, minimizing the low back pain, minimizing also the needs for further surgical intervention, and improving also the quality of life and the mobility of these patients. But the future, in the present now, we have another strategy for regenerative medicine that they using exosomes. Exosomes are vesicles that are secreted from cells containing growth factors. I think that a good option for our research because of minimal immunogenicity. Then in this moment, we won an award also with a Japanese group that will help us for further research in this field. We're happy now with personalized medicine, with tailored surgery, and for regenerative medicine, I wish that the future is bright. Thank you.
Thank you, Professor Papalia. And now, Professor Gerosa, you have created and managed a center of excellence in the field of cardiac surgery. Can you tell us about this experience and on the promises in this field for the next future?
So, the next future is a future devoted to heart failure, no doubt about that, because heart failure is the new pandemic. And as Serafina Valente, who is a cardiologist in Siena, she likes to say the heart failure is the new cancer. According to a paper published in Scotland, the heart failure patients have a worst outcome in terms of survival when compared for the female gender to patient with breast cancer, or according to male gender, patient with bladder cancer or lung cancer. Very recently has been published a paper in JACC Heart Failure where they compared elderly people, so age above 65 years, elderly people affected by cancer, either breast, lung, colorectal, or other type of cancer, and patients with advanced heart failure. And when they compare the quality of life, when they compare the clinical, physical, and mental health status, the patient with heart failure had the worst outcome. So no doubt that heart failure is posing a serious problems. And we have to sort it out. And we can intervene not only as a tertiary prevention, but also a secondary prevention. What I mean? So the heart is not working as a pump, it's not working well as a pump, so we have to replace that pump. So we have heart transplant, is the obvious answer. And all of us are sitting on the shoulder of a giant. When I've been appointed as the chief of cardiac surgery at the University of Padua, I was sitting on the shoulder of Professor Casarotto, two giants, Professor Casarotto and Professor Gallucci, who did the first heart transplant in Italy back in 1985. So I can imagine the legacy that I had to carry on my shoulder with that stuff. And unfortunately, there are not enough heart to be transplanted nowadays. Why is that? Because unlikely kidney, lung, liver, the age of the brain dead donor is constantly increasing. And why is that? Because post-traumatic brain death, I say luckily, is disappearing, is vanishing. Because now it's compulsory, it's mandatory to wear the helmet on the motorbike. And thank God, those donors are disappearing, and those were very young donors. And therefore, now we have a lot of brain dead donors who dies because of stroke or brain hemorrhage. So those are 65, 60 years old. And if it's not a problem for kidney, again, lung and liver is a problem for heart. So we have to sort it out other solution. And I go back to generative artificial intelligence. And I give you this example. Because May last year, we performed the first heart transplant in the world using a DCD donor with a functional warm ischemic time longer than 45 minutes. And if I would ask in January, we did the transplant in May, if I would ask in January to a generative artificial intelligence, can we do a DCD heart transplant using a heart who has been stopped for more than 45 minutes? Generative artificial intelligence say, no, impossible. Because that's what has been published so far by our colleagues, the Americans. But thank God we have the human factor. And the human factor decided that could be possible, and we did that. And actually, it's not important that we did that in May 2023. It's important that since May 2023, in Italy, 7 centers, 7 heart transplant programs have done that transplant using a DCD heart with a functional warm ischemic time longer than 45 minutes in 28 cases, with a 100% success of freedom from primary graft failure. And being an Italian scientist, I'm very happy to say that. And, but again, we can increase of about 30% the number of hearts that we can use, but still not sufficient. So we can look at, as the colleague was pointing out previously, we can look at regenerative medicine, for example, the cellularize a porcine heart and then try to repopulate it with iPS from the potential donor, or we can use xenotransplant. There have been done 2 heart transplants using genetically modified pig hearts. Modified in terms of they were knocked out for 3 porcine genes, alpha-gal, nu5GC, beta-4-gal, and for the receptor for the growth hormone factors, and knock-in for 6 human genes for the complementary cascade and so on. But again, this is a hard way to go, no? Or we can try to create a total artificial heart that should be small. That means it can be implanted in all subjects, and also granting an excellent quality of life, so granting an excellent biocompatibility.
Thank you, Professor Gerosa. Very, very interesting. Professor Durando, you have spoken about multiple sclerosis. Can you tell us more about the innovation in this research field? Are you currently working in some project related to this disease?
Yes, thank you. There is no doubt that multiple sclerosis represents a study model for high complexity chronic diseases causing disability. The strategic importance of employment, maintenance, and job integration, and also reintegration after acute phases of the disease for these workers affected with chronic disease, including disabled one, is reaffirmed as part of European strategy for occupational safety and health, of the European strategy on the rights of persons with disabilities, and also is part of the United Nations 2030 Agenda for Sustainable Development. Our research team, occupational health of the University of Genoa, and the neurologists of the San Martino Teaching Hospital of Genoa participated in a co-founded research program in close collaboration with Associazione Italiana Sclerosi Multipla and from the National Insurance Institute for Against Accident in Rome. to improve knowledge on three fundamental topics concerning this important neurological disease, namely risk prevention, interdisciplinary collaborative networks, and also worker inclusion. The findings of our research project, all published in the literature, was really important. First of all, because we spoke before about innovation in medicine. Also, we explained that to people that also research is growing and changes every year. We use innovative techniques such as the use of scoping reviews and of meta-analysis in order to have a comprehensive knowledge to orientate the work of occupational physicians at a national level, also in close collaboration with the Italian Society of Occupational Health. In this research, literature explained that for a good management of this patient living with comorbidities, with disability, is an interactive collaboration between occupational physician, neurologist, epidemiologist, and also expert in public health is of fundamental meaning. We described also the main worker difficulties and barriers for these workers, and also we try to understand which are the best job adjustment to let these workers have the best capability of work. We speak this afternoon about innovation in medicine, so in this specific context, there is no doubt that during the last decades, immunomodulators dramatically changed the life of this patient, and so also we have better capabilities of their working condition. The availability of supportive devices with technologies also is of main importance, and also neurorehabilitation is really important. A critical point for the occupational physician is to find, together with the employer and the worker himself, the correct job adjustment, the so-called reasonable accommodation, in order to let these people to maintain their work that is part of a good quality of life. The social perspective for these affected workers is really important. Finally, after this first research project, we have the funds also for a second project named Real SM, with other colleagues that is mainly focused on rehabilitation as a qualifying factors in order to maintain a good health and full work capacity depending on the clinical picture of the disease among the affected workers. We plan to publish the first results during the current year, and that's it. Thank you for your attention.
Thank you, Professor Durando. And now the last question about this first panel is for Dr. Cancedda. What is the role of brain research to favor active and healthy aging?
Okay, so it's a fundamental role, and so brain research has the role to first to try to understand the biological processes at the basis of healthy aging, and that would be the basic research. And then second, to find potential therapeutic targets and develop new therapeutic approaches in preclinical models, and that would be translational research. And then eventually test those new therapeutic approaches into the clinics, and that would be clinical research. So the general aim of brain research then would be for healthy aging, not really to treat a disease, but to reduce frailty. So what is frailty then? Frailty is a multidimensional age-dependent condition that really is a state of increased risk for adverse events. So what are those adverse events in aging? Those would be frequent falls, low independence, recovery into hospital and nursing homes, poor ability to recover, and then eventually mortality. So if you think of all of these possible adverse outcomes in healthy aging that contributes to frailty, many of them depend on brain health. So just think about the frequent falls. They do depend on poor motor behavior and poor attention, so two functions that do depend on healthy brain. If you think of recovery in nursing homes, they do depend on poor cognitive abilities and poor social exchange that are also functions that depend on the brain. So in general, brain research, by increasing the brain function, would not only treat, for example, the cognitive impairment, but decrease the frailty and therefore increase the general health of people. Now, if you look at this into even a wider scenario, and you think of that many pharma companies, like big pharma companies like Pfizer, in part Novartis, has in the last 15 or 20 years really closed their internal brain research because of a number of failures in drug discovery. So what is happening now is that the scheme has a little bit changed, and pharma companies like to make the academia the risk for potential target. So what they do finance directly academia to what is called sponsored research agreements, or they do fund or acquire startup companies that derive from academic research. So in this context, academic research has an even wider importance because it really starts brain research. It really makes a lot of de-risking, and it therefore can ignite research programs that would not be started from the pharma, not because it's not interesting or they're not useful or there are no needs, but just because they're risky.
Thank you. Thank you, Dr. Cancedda. And I would like to thank our prestigious speakers for their fantastic interventions. Thank you very much. Because we have listened to many different examples of biomedical innovation, and we have understood that addressing healthy aging requires interdisciplinary approaches and collaborative efforts to foster research for innovative treatments and technologies. Thank you so much, and I will leave the floor to Roberta for the second panel.
Thank you, Luana. Thank you to all your speakers. Panel one, we are a little bit late on the schedule, but please stay, because now we have very relevant international speakers, and Italian, but also international speakers, about that will share their solutions for these determinants these determinants that can hamper healthy and active aging. So please join me, Dr. Ivo Rakovac. Dr. Ivo Rakovac, yes, thank you. Soba Pilati, Marco Silano, Tarundua e Alessandra De Marco. Thank you so much. Please have your seat. So first of all, please, if you can have a seat. Dr. Rakovac serves as Regional Advisor for Non-Communicable Disease Surveillance and Unit Head in the WHO European region, and the Special Representative and Officer in charge of the WHO Country Office in Greece. He's working for WHO since 2010. So, Dr. Rakovac, we all know which are the main risk factors that favor NCDs. Nevertheless, they are growing, and their impact is growing for our healthcare services. So can you tell us what is the real burden of non-communicable diseases, and how can we reduce it, having a positive impact on aging?
Can you hear me without microphone?
Oh, sorry. The microphone, please.
Thank you very much, and thank you for inviting WHO to this excellent event. We are really delighted to be here and to share some of our experience and knowledge with you. So, as we have seen from the speakers before, as we live healthier and longer lives, NCDs play more and more important role. Currently, around 90% of deaths are caused by non-communicable diseases like cardiovascular diseases, cancers, diabetes, chronic respiratory disease. And the proportion is growing year by year. Now, the last few years have been an exception because of the COVID pandemic, but the long-term trends are that. What is particularly worrying is that 2/3 of premature deaths, deaths before the age of 70 years, are caused by those four major non-communicable diseases: cardiovascular diseases, cancers, diabetes, chronic respiratory disease. And even within G7, you have huge inequalities between countries. On the one side, probability of dying before age of 70 in Japan females is 6%. At the same time, for American males, it's 16%. So it's 3 times more. Every 6th American male is dying prematurely because of one of the 4 major NCDs. And globally, only 18 countries are on track to reach the Sustainable Development Goal of 1/3 reduction of premature mortality from NCDs by 2030. And none of those countries is G7, okay? I mean, they are starting from a lower level, but none of these countries are G7. Now, NCDs, I repeat, cause 90% of deaths, but they also cause 85% of disability, 85% of things that cause us our daily pain and limit our daily functioning are basically non-communicable diseases. So maybe it's not so well known, but obesity is the main risk factor for disability in Europe, and it's rising quickly. So we need to remember that NCDs are both preventable, we can prevent them, and they are treatable. If we have them, we can treat them, mostly. So we have basically 2 leverages where we can reduce the NCD burden. And most NCDs are basically caused by 4 behavioral risk factors: tobacco and alcohol use, unhealthy diets, and insufficient physical activity. Those behavioral risk factors then cause metabolic risk factors like high body mass, like high blood pressure, cholesterol, and blood glucose. And taken together, those risk factors cause more than 2/3 of disease burden in Europe. This was the disease burden. Then we have economic burden of NCDs, which, if we do NCD investment cases, we see that it's between 4% and 6% of GDP every year that is burden of non-communicable diseases. This is huge. OECD spoke more about that, so I'll not go into details, but it's 100 billion of euro in the EU for both cancer and another 100 billion for CVD, direct costs in the European Union. And then you have another 100 for indirect costs. And lastly, I would just like to mention that the impact on sustainable development is huge. Impact on resilience is huge. The people who died during the COVID pandemics have been mostly people living with non-communicable diseases. The impact on climate change is huge. 1/4 of greenhouse emissions is due to food systems. So this is where we need to make sure that our diets are both healthy, but also both healthy and climate friendly and sustainable. Maybe in the interest of time, I will stop here with the intervention. Thank you.
Thank you so much, Dr. Rakovac. You mentioned the climate crisis. We have faced a pandemic crisis. And Dr. Soba Pilati is a medical doctor specialized in hygiene and preventive medicine at the University of Verona. She's currently working in the Office of Prevention of Communicable Diseases and International Prophylaxis at the Directorate General for Health Prevention of the Italian Ministry of Health. So we've seen how important are communicable diseases yet, and so how can we prevent them so to favor an healthy and active aging?
So good afternoon. Thank you for the introduction and for the question as well. So communicable diseases can lead to severe health complications, including long-term disabilities, and pose significant public health challenges. And that is why prevention of these communicable diseases is really crucial, not only for maintaining public health, but also for promoting disability-free living. Effective prevention strategies, from vaccination programs to public health education and sanitation improvements, can significantly reduce the incidence and severity of these diseases. And these outcomes improve the overall health and quality of life of individuals. Implementing these straightforward measures can effectively aim to limit the transmission of these diseases and minimize the risk of outbreaks, and ensure that individuals can remain healthy and free from disabilities caused by infections. One of the important preventive methods is to maintain proper hygiene practices, including regular hand washing and use of disinfectants. And furthermore, as it has already been said, advocating for healthy habits, such as following a balanced diet and engaging in physical activity, regular physical activity, and refraining from smoking as well, aids in maintaining a strong and reactive immune system. Nevertheless, vaccination is one of the most effective and efficient ways to prevent communicable diseases, which in turn contributes to the reduction of diseases-related disabilities. Vaccination in particular has shown remarkable effectiveness in preventing a wide range of diseases, infectious diseases, including influenza, pneumococcal infections, respiratory virus infections, COVID-19, and shingles. And contracting these infections during old age can result in a rapid decline in function, which can have negative effect on quality of life, place a burden on health care systems, and increase the number of days of absence of senior individuals from employment and or voluntary activities. That's it.
Thank you very much, Dr. Pilani. Now, Dr. Marco Silano works at the Italian National Institute of Health as the director of the Department of Cardiovascular and Metabolic Diseases. and Aging, and is acting director of the National Center for Rare Diseases. He is also scientific expert of the European Parliament, member of multiple working groups at the Italian Ministry of Health that address public health issues. Dr. Schillaci, we've mentioned it in many times. Tell us something about the role of nutrition for our healthy aging.
Thank you very much for the invitation and for the question. Yes, nutrition is one of the main determinants of healthy aging. In the very nice introductory video about of this session, we have learned about the blue zones. The blue areas, the blue zones are small communities around the world where the number of centennials is much higher than expected. And very important scientific studies have demonstrated that genetic is responsible for 25% of this achievement, but 75% of the number of the centennials in these communities is due to the healthy lifestyles, and nutrition is one of the most important. The nutrition in these communities is characterized, first of all, by frugality. Nowadays, in our latitude, is very famous, is very common talking about calorie restriction. People in these communities, in the blue zones, perform calorie restriction every day, eating only what they need. In addition, their dietary patterns are characterized by vegetable oils, by proteins mainly from vegetables origin, very small quantity of animal proteins, and a lot of vegetables, fruits and legumes as main proteins. Most of these people produce by themselves the foods, performing also physical and regular activities every day. It does not mean that they go to the gym regularly every day or 3-4 times a week, but in the regular daily activities they don't use cars, or the use of motor vehicles is very limited. So they go walking, they use in the background to grow their fresh foods that they use in their daily diet, just cooked or very low processed. So maybe this is the dietary pattern that can help an healthy aging.
Thank you so much. Dr. Tarun Dua is a medical doctor, currently the head of the Brain Health Unit in the Department of Mental Health and Substance Use at the World Health Organization. She is also responsible for all activities concerning neurology within the organization, specifically the 2 World Health Assembly mandates related to neurology and dementia, the Intersectoral Global Action Plan on Epilepsy and other neurological disorders, and the Global Action Plan on the Public Health Response to Dementia. Dr. Dua, we've already heard about the importance of brain health, but can you tell us something else from a public health perspective? How can these issues, can they be addressed?
So thank you very much. I join my colleague, Dr. Rokovac, in thanking the organizers for having the World Health Organization. So Ivo talked about the non-communicable diseases. So let me add on in terms of the challenges or the issues when we see in older adults, when we look at mental and brain health issues. So we have seen the data that has been presented, that population is aging, the demographic transition that we are seeing. One of the misconceptions that very often we hear that this is for high-income countries, that it is an issue. But the demographic transition is happening globally, also in low and middle-income countries. So if you think in terms of by 2030, in 6 years' time, 1 in 6 person will be over the age of 60 years. So these are huge number of we don't like to call them older adults. Age is just a number, but still, if we think in terms of over 60, these are huge number of people we are talking about. We heard about the non-communicable diseases and the deaths and the DALIs that we see in older adults. What about the mental health issues or the brain health issues? So 14% of these people over the age of 60 will have one of the mental disorders. So this is huge. And we have seen after COVID-19, because of social isolation and even a direct impact of COVID-19, more and more people are having mental health issues. We already heard about dementia, and other neurodegenerative or other neurological conditions, like, for example, stroke. So many of these peak in the early life and later life. So you have currently 55 million people with dementia. And if I try to convert this into something that is really happening, one of the conferences, Dr. Peter Pio, who was at that time head of the London School of Hygiene and Tropical Medicine, he said dementia is a ticking time bomb. We have a person diagnosed with dementia 1 in every 3 seconds. So I'm counting 1001, 1002, 1003. We have one more person with dementia. So this is huge if we think in terms of the burden that is on the society, if we think in terms of the burden that is on the medical care costs or the care families that is happening. So now these are the huge numbers, and the issue that comes in, okay, what can we do? How can this be prevented? What are the risk factors? What are the protective factors? So from WHO, we published a position paper on these determinants. And one of the important things that is coming, that is very important, that when we think about the determinants of mental or brain health, these are intersectoral. We need a multi-sectoral approach to target this. So health plays a huge part. Physical health issues, for example, the comorbidity that we see. So non-communicable diseases and depression, anxiety. HIV, depression, anxiety. And what comorbidity does is that it increases your mortality, it increases your disability that you are seeing. Then there are, we talked about, like, for example, diabetic neuropathy, the impact, the other issues that are related to physical health. The second is the healthy environments. And some of these things, they accumulate over, there is a cumulative effect over life. For example, if you are thinking in terms of air pollution and the things that is happening because of climate change. Learning and social connection. Learning, for example, starting from early years, maternal education. So somebody talked about the impact, the preconception. So how this is important to prevent many of these maternal and brain health challenges that we see. And the other issues that are related to, for example, safety and security, like the issues such as elder abuse. So there are many challenges. And thus, we require this public health approach where we don't take a single disease model, but an integrated model to take forward.
Thank you very much. Alessandra De Marco now. She's been Director General of Information and Institutional Communication Office of the Department for Information and Publishing of the Presidency of the Council of Ministers in Italy since 2016. So we know how relevant communication is. What was the role of the institutional communication during the recent pandemic, and which lessons we've learned?
Well, thank you very much for having invited me to share this Italian experience in this panel. Institutional communication has been considered a tool for public health since the 1970s, but is with the 2019 pandemic that its role has been widely appreciated all over the world, because in that years, government of all the countries were busy in developing and diffusing public communication campaigns to contrast pandemic with two objectives. The first was to help to make individual choices in a context in which infodemic was arising for the first time. And the second objective was to promote positive collective behaviors that were considered useful to reduce the spread of the virus. The Italian Prime Minister Office was busy with this task together with other ministries, first of all the Ministry of Health, and we made efforts together with a number of relevant campaigns. The main one maybe that Italian citizens may remember is the campaign to promote vaccination against COVID that lasted 1 year and was an opportunity to introduce and use some tools that has been used primarily in the private sector. I mean target analysis, the development of content for multi-channel diffusion, and measurement and assessment that were not so common at that time in the public communication offices all over the world. So this experience has resulted in an increased administrative capacity as well as an experience in the use of new methods and techniques. And since that period, we are trying to follow this path, introducing this technique in our daily, work. And in my opinion, this can be also useful for lifelong prevention initiatives in the field of communication. The 3 lessons that I would like to share with you that may be useful for this objective is the one referred to continuity. To be effective in campaigns and in trying to influence behavior, making people adopt positive and suggested behavior, is to have a clear mid-term objective. And this mid-term objective must be the focal point for a communication strategy that studies the target, the content, the media, and that's so on, and whose results are continuously evaluated. This is more challenging for when lifelong prevention is involved, because it's not a question of raising awareness or a question of informing, but it's a question of making people choose to change. And this can be very tricky, and I think the future scenario will see our offices using behavioral insight much more than now, in which there are some experimental projects, but they are not widely used. The second point is about content, because there is the need for develop engaging content that is really that has a potential to convince people. And here today I heard a lot about innovation and AI, and I think AI can give a contribution to public communication as well, because can help to develop very quickly highly personalized content based not on sensitive data, because when prevention is involved, many data that refers to people lifestyles can be useful. So in the full respect of privacy, obviously, of privacy and ethics in using data, but there is another field to explore, building on our experience, is to try to develop more focused and targeted content for specific targets. And then the third is the lesson I am more interested in, because it's about cooperation. Because the COVID-19 years saw a lot of cooperation of public administration with other relevant public and private bodies. But I think in prevention, this model can be replicated, and in a context in which infodemic is not necessarily a threat, but can be an opportunity, because there are many bodies that are suggesting to adopt a healthier lifestyle. Thank you so much for the attention.
Thank you. Dr. Rakovac, you heard about what Dr. De Marco said about the importance of communication to improve lifestyles. Which are the strategies of the WHO in this sense, and the role of the WHO Europe in this context? How to promote healthy lifestyles?
Thank you. Thank you very much.
No?
No. Yes, thank you. So the WHO maintains a menu of very effective and cost-effective options, things that can be done in order to prevent and treat non-communicable diseases. Those are called NCD best buys and good buys. Official name is Annex 3, but nobody knows Annex 3, so it's WHO best buys. And basically, we have collected evidence that 90 interventions are very effective and cost-effective to a certain extent to prevent and treat non-communicable diseases. In addition, we have 22 overarching or enabling actions that are important for prevention and control of NCDs. So what are those interventions? In essence, we are seeing that interventions that reduce availability, affordability, and eliminate marketing of unhealthy commodities like tobacco and alcohol are the most effective, okay? So we need to help people make the right and healthy choice. And this we can do by regulation. This is the role of governments. So here I would also like to mention, for example, sugar-sweetened beverages, and we should be also importance of communication. We should be also warning the users of unhealthy commodities of their adverse health effects. For example, it's very difficult to find a health warning on a bottle of alcohol in Europe. It is something where we all need to improve. But there are also many, many good examples. For example, if you look at Nutri-Score in France, it is really a very good system that has been now adopted by more and more countries across Europe. If you look at the role of the European Union in putting large graphical warnings on cigarettes, this has been really a major achievement in Europe. If you think about the role of the European Union in banning trans fats, this has saved millions of lives. So regulation really works. You don't have an option in EU to buy something that's cheap and contains trans fats. It has been eliminated from the food system. So those are the most effective interventions. We should, of course, also be creating enabling environments and promoting health. For example, subsidies on healthy foods, creation of health-promoting built environments, and public transportation that would support physical activity. We need to have safe sidewalks, safe bicycle lanes. Otherwise, people will not take bicycles to their workplaces. They will take cars. But we need environments like in blue zones where it's safe to walk around. I would also here like to emphasize the importance of digital environments, something that I have not heard today. Basically, each of us spends at least 7-8 hours online. And we are online being bombarded with marketing of unhealthy products and so on. So I think the time has come that we make digital environments safe for all people. Also on the list of options, we have early detection and treatment of cardiovascular diseases, where I would like to emphasize the example from Canada with very effective detection, treatment, and control of hypertension, which really have saved millions of lives. And then especially selected cancers like elimination of cervical cancer, because cervical cancer is both preventable and treatable. And actually a disgrace that women are dying nowadays also in G7 countries because of cervical cancer. A condition can be both eliminated and treated. For example, we have here also breast and colorectal cancers, which are very cost-effective to treat. Importance of life course approach, lifelong prevention has been emphasized several times, and we fully support this. But we should also take into account the whole disease pathway. This means prevention, treatment, secondary prevention, rehabilitation, and also palliation. And WHO best buys are very cost effective. As you have seen on the data from the OECD, we have the similar data for WHO best buys. And for $1 US invested, you get $7 of return of investment over 10 to 14 years. The last point, maybe in this of time, we really need comprehensive policies. One or two interventions will not do it. We need a comprehensive package that will tackle as many things as possible, depending on the political momentum in the countries and will. What need to be implemented, what can be implemented using good data. And we need really good data and evidence for this. Maybe the last thing that I would like to emphasize, we need to invest more also as developmental assistance for health for NCDs. Only 2% of international developmental assistance for health goes for NCDs. And they cause 90% of burden also in low and middle income countries. And this is also where G7 has an important role. We will have the next UN high-level meeting in a year on NCDs. And we are totally off track to reach the NCD targets. So we all need to act now in order to turn the tide on NCDs. And we count on you, because only together we can make this change. Thank you.
Thank you. Dr. Pilati, you have already mentioned what we can do for the prevention of communicable diseases in the life course of people, but can you please focus on the elderly? What's most important for them?
Thank you very much for the question, because actually this is really a crucial point. What are we doing for elderly population and as Ministry of Health, and for promoting disabilities-free living? So I intentionally mentioned before to pneumococcal infections, shingles, influenza, respiratory syncytial virus, and COVID-19, because elderly population is more susceptible to these infections, which can also result in long-term disabilities and severe health complications. And for instance, pneumonia, meningitis, bacteremia, hospitalization, and permanent disabilities, as well as some of the potential complications of these diseases, particularly in older individuals. Also, COVID-19, despite the fact that the related global health emergency has been declared over, does still represent a risk for hospitalization and long-term disabilities. And shingles can result in postherpetic neuralgia, PHN, a severe form of nerve pain that can substantially reduce quality of life and result in long-term disability. Nevertheless, there are specific vaccines and vaccination programs and recommendations in place for these diseases. And the Italian National Vaccine Prevention Plan 2023-2025 includes targeted immunizations for older individuals, such as those for influenza, pneumococcal infections, and shingles as well. And according to this plan, influenza vaccination is recommended and free of charge for all people aged 60 and older. In light of the epidemiological situation regarding the circulation of respiratory viruses during the previous season, the Ministry of Health provides annually guidance for regions on flu prevention and control measures. The pneumococcal vaccination and the shingles vaccination are also free and recommended for individuals aged 65 and older. Regarding COVID-19, the Italian Ministry of Health launched the National Autumn and Winter 2023-2024 immunization campaign with specific goal of protecting the elderly and persons with high frailty. The updated vaccine formulation was recommended and a booster dose was offered to these groups of individuals 12 months after their last vaccination. In March 2024, the Directorate General of Health Prevention informed the regions about prevention and immunization measures also against respiratory syncytial virus. To ensure a uniform approach without disparities, the Directorate is activating any necessary procedure to update the vaccination calendar, starting with the advice of a technical advisory group on immunization, NITAG. Just to conclude, the prevention of infectious diseases in the elderly, entailing the prevention of severe consequences, allows the elderly to maintain independence, well-being, and active social engagement.
Thank you. Thank you very much. Last April in Paestum, there was an event to celebrate the Mediterranean diet. You have already mentioned without naming it. Can you tell us something more about this and which are its benefits? Because the Mediterranean diet is a UNICEF good, protected by you.
For asking. The diet I referred in my previous answer are called overall the traditional diets, because these dietary patterns are close related and linked to the tradition of the communities, and very often the recipes are inherited from a generation to another. The Mediterranean diet is probably the best known, the most widely known among the traditional diets, because Ansel Keys firstly described the Mediterranean diet back in the 50s when he visited the Greek island of Crete and the Italian region of Cilento, where Paestum is probably the largest city. Beside the foods of the Mediterranean diet that are the foods I have already mentioned, the Mediterranean diet is characterized by conviviality. Conviviality is a main feature of the traditional diets, generally speaking, but mainly of the Mediterranean diets, and it means that the food is and the meals are shared between the people, and that the conviviality, the joy of having meals all together is a part very important to make the right attitude of the people towards the foods. In addition, the physical activity is also deeply embedded into the Mediterranean diet, because as I have already the opportunity to say, also now at the present time in some regions of Italy, people is still producing the fresh food that is going to consume in their daily diet and daily meals. And also the tradition, so the recipes that are transmitted and brought from the different generation. But there are some bad news about the Mediterranean diet, the adherence to the Mediterranean diet also in Italy, that is the cradle of the Mediterranean diet, because some data from a study of my institution, from my group, and founded by the Italian Ministry of Health, this result have shown that in Italy only 5% of the population still follow a Mediterranean dietary pattern. There are several reasons of this poor result. Mainly is not the cost, because at least in the Mediterranean basin, the food, the raw material for the Mediterranean diet are not much more expensive than the processed foods, but it's time. What now people don't have but need for follow a Mediterranean dietary pattern is time, because there is long cooking time for having a Mediterranean diet food, or also there is a long art-man craftsmanship behind a Mediterranean dishes. So this is something that we have to work on with the competent authorities, so to again develop the Mediterranean diet also in the regions of the Mediterranean basin.
Thank you. Dr. Dua, we've heard about the importance of brain health. Which are the main strategies to get this?
Let me use the example of dementia, specifically using that as a concrete example. And there are three points I would like to make. So first is in terms of the evidence. As we think about the risk factors for dementia, what is the evidence that we have for various risk factors? So as WHO, we have published these guidelines on reducing the risk, and they are across the three different categories. One is healthy behavior. So we heard about the Mediterranean diet and physical activity, and then tobacco, alcohol. So we have heard about all of that. The second categories of the risk factors are related to treating many of the physical health conditions, the non-communicable disease conditions. So if you have high cholesterol, if you have diabetes, hypertension, so these are the risk factors. And then we have risk factors and the interventions that are related to cognitive stimulation that are extremely important. Now, the point that I want to make here is that 40% of dementia is preventable, is by these modifiable risk factors. So if we are, and these are risk factors, we heard they are important for preventing non-communicable diseases. So there is a lot, if you think in terms of the return on investment, that my colleague was earlier talking, it will be huge, it will be much more, because we haven't looked at the dementia as an outcome in those return on investments. So what we say is what is good for heart is good for your brain, and vice versa. And there is much more that we need to do beyond that. Now then, there are other categories of risk factors which we need to start thinking about, and especially like in older adults, that as we are thinking about social connection. How are we implementing these strategies to take into account the social isolation, and how that can be, how can we work on that? Then risk factors such as hearing loss, sleep. Earlier, in the opening session, we heard about women's health, and so one of the things is in menopause. There are higher risk of dementia. So how can we look at these interventions? And some of this we are doing through our update of the evidence and having these guidelines. So that was my first point in terms of we know about these interventions, we know what can be done about it, we can prevent, we can modify these. The second point that I want to make up is about how do we implement these guidelines through policies, through trainings, and as my earlier speaker was saying, unfortunately, we see a lack of policies, and even in many of the high-income countries, you don't have policies for dementia. You don't have any of the risk reduction campaign that is needed. And what you were talking about earlier, like what we saw in COVID-19, this is true. I was making notes that you need the continuity, you need engaging content, and you need cooperation. And these are something that we need to do for risk reduction to implement these policies, because the cost of inaction is huge. So you mentioned earlier physical activity. So if we do not change the rates of physical activity, we are going to have additional 500 million cases of non-communicable diseases, huge numbers. And this will be 50 billion of cost per year, additional cost that we are seeing. And now out of these, only of these NCDs, only 3% of these due to lack of physical inactivity are dementia. 20% of costs of this 50 billion is due to dementia costs. So this is kind of a call for all the countries, including the G7 countries, in how do we invest in better policies, better strategies. And I liked one of the earlier speaker talked about 3 approaches, and I think that's a good one for every country to adopt. One is the primary healthcare approach. Second is the community-based approach, and third is the workplace approach. And I'll modify the workplace to include our education sector, the employment and education. And we need to have that multi-pronged way if we need to, if we need to have these strategies, and if we have to, decrease the costs that are we seeing due to non-communicable diseases, conditions, mental health conditions, and dementia.
Thank you very much. Now, thank you. We go back to what you said about the tools that you used, tools also from the private sector. Can you focus on the young people as target for these campaigns?
Yes, well, it's a tricky question because young people are a little bit challenging as target for public communicators because they are not interested almost at all in what the institution are saying. And in our experience, the campaigns that work best are the one in which we give something. For example, the campaign with which we promoted the bonus for an amount of money that they can use for cultural consumption or for promoting the civil service, that is an opportunity to do an experience, a paid experience. But I think that campaigns that aim to reach young people may be built on 3 pillars that are choose a relevant target, the right media, and the effective payoff. Relevant target because when lifelong prevention is involved, young people are not all the same. Young people are a universe. And so maybe some of them are already in a social context in which healthy lifestyle are considered, are supported, are suggested. While there are others that do not have this opportunity because, for example, they do not play sport, they have not experienced it in their family, some medical problems. And so the first thing is to decide which target to address. And in my opinion, the public must address the weakest, so the ones that are less exposed to this content. As for the media, there is an interesting survey that we conducted last year at the Department for Information and Publishing, which shows that almost 50% of Italians get information daily on two main sources. And these two sources are only the social media. And this target uses social media with quite a deep approach, sectoral approach, not for overall information. And most surprisingly, there is a target that we named the distant citizens that mainly use word of mouth to get information. That word of mouth 2.0 I call, because it's messaging services with friends, WhatsApp, Telegram, and that's all. And so the majority of young people belong to these two clusters that we have identified. And so the development of campaigns for young people must necessarily take into account the social and digital environment. It's not easy because it seems a panacea. In the past year, I hear a lot of my colleagues say, okay, let's go on social. We are making a video that is going to be viral. No, it's not like this. Now it's a fully professionalized sector that where there are people that work on this with a lot of experience. For example, one of the emerging trends is that influencers, general influencers, have been are being changed, and the content creators are rising while general influencers are decreasing. And we have an experience in the use of influencer. Also, the Ministry of Health has one with the very effective blood donation campaign. And we used, for example, Kabilame for diffusing a message against discrimination. But maybe when permanent changes in behavior are required, we should think seriously about involving a number of content creators for a mid-term. So sharing values and sharing the content to engage young people. And the third point is the effective payoff. It's not easy to find an effective payoff because for young people, the evaluation of the pros and cons of short-term sacrifices, not drinking a lot of beers, not eating sausages every day or McDonald's, hamburgers, compared to these long-term benefits can be less attractive. And so here again, I think an in-depth analysis of behavioral insight must be taken into consideration, as well as the development of payoffs, the definition and the proposal of payoffs that can be socially adopted in the social context. That is one of the characteristics of the Italian society. Thank you for me.
Thank you very much. Thank you very much to all of you. Thank you for staying so late. It was a very, very dense and interesting day, but tomorrow we have 2 more sessions. We'll go even deeper into these issues so important. And so thank you very much. We say goodbye, good evening, and we will meet here tomorrow at 9 o'clock. Have a nice night and enjoy Genoa.